Yes, a minute to arrive. Thank you, Michael and Catherine. You're very welcome. You're part of the furniture here now. Just to advise yourselves that obviously now at this point the committee wanted to discuss the proposed amendment that you've brought forward now on your letter of the 1st of April. Just advising yourselves as well that we've discussed the proposed amendment to clause 7 and we're generally content with the approach as outlined. We noted in your covering letter that you stated that the powers will be exercised in the first set of regulations drafted after the Act comes into operation, and I suppose that's something we just want to drill down with you. We would like that obviously to be tied down more firmly, and therefore we're requesting as a committee that you would seek that written assurance from the Minister that this will be the case. Obviously we would seek that assurance before we would do our clause by clause reading, which is next week. So I would ask that on behalf of the committee that you would pursue that with the department as a matter of urgency. Are other members content with that request or any other commentary around it? Can I just seek that agreement then that you will do that?
That's not a problem. We're happy to do that. The Minister was made aware of the proposed amendments and has already agreed to those. And it was always our intention that where there were regulation making powers that were required to bring any aspect of the scheme into implementation, that would all happen at the same point in time. So there would be no difficulty in including this as part of the process of the initial regulations. Okay,
and the Minister has already given approval for the proposed amendment?
Yes, he has.
And do you envisage that there would be no issues in seeking this approval now, or seeking this assurance that it would be activated and we could turn that round before next week?
Yeah. That shouldn't be a problem.
Okay, great. That's all we needed to hear from, and thank you for your time.
Thank you. No problem.
Okay, members, item 4 is chairperson's business. Number of items to reflect on. First of all, just to say that the committee had a very successful visit to Scotland, and thank the clerk and the staff of the committee for making it a success, and indeed the members who attended. We met with representatives from the Scottish Communities for Health and Wellbeing and from the Healthy Living Alliance in the north here on the Wednesday, and their focus very much was on community-based models for tackling health inequalities and preventative spend. On the Thursday, we then met members of the Health and Sport Committee in the Scottish Parliament. There's a number of items coming from that by way of follow-up, so if I just reflect on that and seek agreement from members. First of all, that we would go back and seek the Scottish Committee's views on community-based model for tackling health inequalities. We had raised it at the committee, but to seek those views in writing, and that's the model that's promoted by the Scottish Communities for Health and Wellbeing. Secondly, information on the new Scotland Children and Young Persons Act 2014. Also information on the IVF provision in Scotland, and information on the Scottish Committee were very clear that their traditional service delivery of health has shifted back to what they called a cooperative traditional NHS model. So I'm suggesting that we would seek clarification on that, what that model looks like, so that we would do that as well. Also information on the powers exercised by the Scottish Parliament in terms of altering GP contracts, which was one of the issues that we had raised with them as well. And information also on the proposed changes to ages at which cervical screening is carried out, and information on the e-petition mechanism, which was raised with us as well, that's used in the Scottish Parliament. So members in agreement that we would seek that information and obviously reflect it back here at committee.
Great.
Also just want to advise members that myself and the clerk met with the new interim chair of the Safeguarding Board on Monday of this week. The department has appointed an independent expert to undertake a review of the Safeguarding Board to be completed by December 2015, seeking agreement members to write to the department to request the terms of reference for that review and the timetable for bringing forward any changes as a result of the review. Members agreed?
Agreed.
Another item in relation to the infrastructural programme, if members recall, this was raised at our recent evidence session with the department. The infrastructural programme, which is just over 4 million, which is allocated to a number of mostly community and voluntary sector organisations. There was confirmation, clarification given that day by Julie Thompson that no changes would take place to the programme until there was proper consultation with the sector. My understanding is that no payments have been issued since the start of April, and I would seek clarification from the department and the Minister as to the current status of that programme and any proposed consultation or communication with the sector. Finally, members, the committee sponsored an event this morning. I know a number of members were in attendance on Dementia Care, the Right to Know campaign. I'm seeking agreement here that we would write to the Minister asking him for his endorsement of the Right to Know campaign and what he would, or the department would intend to do in relation to it.
Agreed.
Okay, members, thank you. Item 5 is the minutes of the meeting on Wednesday the 18th of March, which are on page 24. Are members content with the minutes? Item 6 is the update on the committee's report on waiting times for elective care, which is departmental briefing. Just referring members to page 5 of your tabled booklet. And I think we're waiting on our guest to arrive. Okay, folks, just let you get settled. I thought you were going to stand us up there.
Timing was just slightly.
Okay. Well, you're very welcome. We have Deborah McNeely, Deputy Secretary, Healthcare Policy Group at the Department, Dean Sullivan, Director of Commissioning at the Board, and Alison James, Principal Officer, HSC Performance Unit at the Department. I think Fiona Hamill had sent apologies. So you're very welcome. I'm just going to hand over to yourselves to make the presentation. We'll open it up to members' comments or questions.
All right, thank you very much, Chair. Good afternoon, and thank you for the opportunity to provide an update in respect of the commitments made by the Department in response to the recommendations arising from the Committee's report on the review of waiting times. We've provided a briefing paper, and hopefully that's in the folders in front of you, which outlines our position in respect to the report's 5 recommendations, which I hope you find useful in terms of the context and background. Before I go through each of these in turn, I don't intend to go through them in detail in turn, I'd be glad to know. Just say a few words about waiting times in general. I recognise the committee's concern regarding the length of time people are waiting for elective care, which is the reason, obviously, the issue was one of your strategic priorities for the 2013-14 Assembly session. Whether we like it or not, waiting lists are seen as a measure of the state of the health service and are judged as an indicator of its performance. When they lengthen, this affects the public's confidence in the health service, and they're obviously concerned about will they be able to get help when they need it. We are acutely aware of the rise in demand and the financial pressures the service is under, mean that some patients are waiting longer. Those urgent and of the highest clinical priority will always be seen more quickly, but others will be concerned about how long they will have to wait. I wish to assure you that the health service here will continue to do its utmost in the resources it has available to it to ensure the clinical needs of patients are met, that patient safety is maintained, and that patients do not wait any longer than they have to. Moving on to the first recommendation of the report, which was that the Department introduces a system to measure referral to treatment times for elective care and to set corresponding targets. The Minister gave a commitment that we would review the experience of other parts of the United Kingdom in introducing referral to treatment targets to better understand the scale of the investment required to do so and the potential benefits to see if such an investment could be justified at the present time. This has now been done and details are provided in the paper in front of you. In terms of the findings of review that are set out in the briefing paper, I would just like to highlight or make a few observations. Firstly, we remain of the view that the referral to treatment targets are a better approach than the one we have and should be the direction of travel because they provide a clear picture of the complete patient journey time and they stop patients from being lost in the system as they are tracked and also reduce clinical risk. And there's been evidence that the clinicians and the evidence that was put before you clearly supported these types of targets. Whilst we recognise the benefits of such targets, the question has always been and remains whether we would be able to introduce these in practice. In considering the key aspects of the approaches taken by England, Scotland and Wales in introducing referral to treatment targets in their areas, be it the policies that are in place which define how the reductions in waiting times will be delivered, sufficient funds to enable them to deliver such policies, success on the ground in delivering reductions in waiting times, sufficient capacity to meet demand to deliver referral to treatment targets, including the use of the independent sector, when necessary, and to be able to measure in practice the complete patient pathways. We have concluded that the existing financial pressures and lack of any assurance on future funding does not put the Department in a position where we could realistically take similar action at this time. I know this will be a disappointment to the committee. It is something that we share in terms of that disappointment, but we can't realistically give any commitment to the introduction of referral to treatment targets when we have no means of putting them in place in practice because significantly the financial constraints that we are facing at this point in time. Even to simply measure complete patient journey times without setting any form of target presents significant difficulties in itself. Looking at the approach taken in Wales to measure their targets, we estimate that to do something here would require us, for example, to collect and link information at individual patient level for outpatients, diagnostics and referrals, and to link the diagnostic data on local systems. Now, in the positive side, we are taking steps as part of the electronic care record to link systems and to aggregate systems, but this of itself will not provide the silver bullet necessary to get to a full referral to treatment ICT target, although it's a positive step, including the introduction of e-referrals more recently. In terms of moving on to recommendations B and C, and the introduction, which recommended that the introduction of referral to treatment targets are accompanied by new arrangements for managing performance and a clearly defined policy on how compliance would be enforced. We advised that both recommendations would be taken forward through the review of administration, which is ongoing. Work to date has included an exercise to identify any duplication of key functions between the Department and other regional bodies, and the Department is also liaising with the Board and regarding engagement between Trusts and the Board and the Department to ensure consistency in reporting of performance, because there's different reporting going on at the minute, and it's important that we streamline our processes to avoid duplication in relation to that, and that we build on that process. We are also expecting to refocus the monthly performance management reports that we receive from the Health and Social Care Board to the Department, focusing more on the trajectories for change in terms of improvement and focusing more on the actions taken to deliver better outcomes in relation to the elective targets. With regards to recommendation D, the Department produces an action plan detailing how it will decrease spend on private sector elective care over the 3 to 5 years by making better use of in-house health service-based solutions. This has always been the stated aim of the Board, where the use of the independent sector has always been intended as a short to medium term measure to bridge the gap between funded capacity and patient demand. Unfortunately, by circumstance more than design, the current financial position will result in a significant fall in the use of the independent sector in 2015-16. And I think this was something that we alluded to and covered when we were here on the budget a few weeks back with Julie. There is expected to be a small increase in recurrent investment in-house next year in elective care, and that will have been reflected in the papers that you've received. But this will be in no way sufficient to address a significant shortfall in resources for elective activity compared to previous years. All of this, and the Minister is on record in relation to the funding constraints and the impact on services, the detrimental impact on services that cannot be delivered as they're currently being delivered. So even with additional funding through in-year monitoring rounds, in terms of addressing the elective lists at the minute, we wouldn't be able to get them back to the place that we would expect them to get in this financial year, even if there was funding available. In the meantime, the Board is focusing on ensuring trusts deliver their commission volumes of core activity in all specialities, along with strict chronological management of waiting lists to maintain existing waiting times. In relation to recommendation E, that the Department develops policies which proactively mitigate against the potential conflicts of interest which exist for doctors who carry out private work as well as working in the health service. The potential for, as you're aware, for this conflict of interest has long been recognised and was addressed by the introduction of a code of practice for private practice in November 2003, and you'll be aware of the Department's guidance on the management of private practice in health service hospitals in Northern Ireland, which sets out key principles, including that consultants and their employing organisations should work to prevent any conflict of interest. At this stage, as we've made clear before, the Department has no evidence that consultants seek to divert patients to private healthcare or to underperform in the public sector to maintain long waiting times. Nonetheless, we are meeting with the Patient Client Council with a view to seeing if it can undertake research along the lines suggested by the committee, and that meeting is scheduled to take place next week. This concludes my opening remarks, and of course we're happy to take questions.
Okay, thank you, Deborah. I think it's suffice to say it's disappointing.
Yes.
Certainly, from my read of this, the 5 recommendations that came out of the inquiry have all been rejected.
I think the biggest impediment for us at this point in time is the resourcing issue, and you'll be aware of the waiting list statistics in terms of elective that were published recently up to the end of December, which showed the deterioration in the position up until that period, and that is in some measure, some large measure, due to the fact that there are now paused patients in relation to elective care, and that we have not been able to spend in 2014-15 the money that we would have liked on the independent sector. Going into 15-16, the position is increasingly difficult in terms of the finances, and that of itself, I believe, is the biggest impediment for us in terms of introducing a referral to treat target, because one of the key requirements highlighted in the NHS guidance was that in terms of a referral to treat target to work, the most important aspect was that you had sufficient capacity to meet existing demand, that you managed your capacity in a way to meet demand, and at this point in time, because of the resource position, we just do not have the core capacity, the capacity to meet demand, and that is our biggest impediment in terms of implementing a refer to treat target, because we'd be measuring something which is inherently difficult, because patients are waiting too long at the minute, and 3 parts of the journey is just going to show that they're still going to be waiting that length of time. It's not going to improve performance at this point in time in terms of the patient's journey, because simply we're unable to make inroads into the waiting lists as they currently sit.
But is the reduction of waiting times for elective care a departmental priority?
Yes, it is. Yes. But it's within the construct of the budget that we have. There are numerous, different departmental priorities, and it is a departmental priority. You're quite right, but nonetheless, we have only been given a certain amount of money to spend it, and that has been even at that, you'll be aware, had trouble in balancing our budget for 2015-16. We hadn't quite got there. We still haven't quite got there, at this point in time. And therefore, even with all of the work that has gone on, there is clearly unmet need out there, and we are, short on resource to be able to make significant inroads into this.
But it would fit clearly with the policy direction of transforming your care.
In terms of the policy direction of transforming your care, in the context of keeping people out of hospital and treating them in the community and avoiding them maybe going either to unscheduled care or elective care, yes, all of that sits together as part of the holistic journey. So, you've got all of those joined up priorities in terms of the holistic system. So it does fit together, but again, in terms of taking forward all the different work streams, there's only a certain amount of money, to go
Then
around.
you see, what I don't get in this at all, Deborah, is that, paragraphs 32 and 33 of your paper talk about the lead-in time that will be required for a referral to treatment. And that was the whole emphasis that came out of the inquiry, the need to look at the entire patient journey in relation to waiting times. But you keep referring to no overarching policy in place. There is an overarching policy, it's TYC.
You're quite right, there's no overarching policy in terms of the direction of travel, as in you want to keep as many people healthy in the community for as long as possible and treat them there. In terms of the reference to no overarching policy in relation to refer to treat, whenever they're talking about the policy in England, it's about which pathways do they measure, how do they measure, what are their priorities, what are they, I think I'm keep writing, that's how they have described their policy in terms of refer to treat. But if you're talking strategically, TYC.
Yeah, but then why does your paper then say no overarching policy in place and this would need to be developed?
If I sort of can step in here and explain that, in England, Scotland and Wales, what we did was look at the referral to treatment targets they had put in place and then track them back to see where they had come from. In England, around 2000, they developed a 10-year policy, and a clear focus of that policy was reduction in waiting times. Likewise, for Scotland and for Wales, they introduced similar policies with a primary focus of reducing waiting times, and those policies set out on the ground how they plan to go about it. In relation to transforming your care here, while it's quite similar to Scotland and Wales, where they were looking to shift services into the community as a means of reducing waiting times, transforming your care here does not have a specific focus on reducing waiting times. It's more about delivering services in a better way.
In a better way in terms of
but
delivering
it doesn't have, and I actually checked this at the time to make sure that there's no explicit reference or focus in transforming your care to reducing waiting times. It should contribute to reduction of waiting times when it's implemented. There's no doubt about that. But what we were basically saying in the briefing paper is, if we were to consider setting a target about reducing waiting times, specifically to the degree that you would require for referral to treatments, which is quite a significant drop in waiting times, you really have to work out on the ground, aside setting a target, how you're actually going to achieve it. And England, Scotland and Wales took different approaches to that.
But we have been setting targets for quite a number of years.
We have been setting targets through the Commissioning Plan Direction and Priorities for Action every year, and those targets were basically following on from what England had in place before they introduced the referral to treatment targets.
Right, okay, so if we're saying we have a policy direction which is attached to, where reducing waiting times for elective care fits,
Yeah.
but there's something missing. What is it? What is the policy bit that's missing then?
I suppose the thing that we're just missing is to really just sit down and think on the ground. If we were to reduce waiting times significantly, exactly what do we think we would need to do here to do that, in order to achieve it? And what you see from the policies elsewhere is they had different approaches to doing it.
Yeah.
For example,
could I maybe contribute here, Chair? Because there is a risk of us having a range of discussions over in the corner of the room that there's, in simple terms, there are patients waiting today far too long to be assessed following referral by GP, far too long to have a diagnostic test, and far too long to be treated. Now, as Deborah, I think, alluded to in her introductory remarks, by all means, I would be the first supporter of a referral to treatment target. I see the benefit of that. But there would be no value at all in having that unless, in parallel with that, we had a plan in place that was appropriately resourced for an appropriate period of time to bring the waiting times down for the assessment period, for the diagnostic period and for the treatment period. All you would be doing would be adding up a series of increasingly long waiting times for the three of those things. So from my perspective, the prime issue here is not the referral to treatment target, by all means as a longer term place that we might want to get to. The far more immediate issue is, as things sit today, coming into March, out of March into April 2015, we have ridiculously long waiting times for assessment, for diagnostics and for treatment, and those are going to get longer in 15-16 in the context of the resources currently available to us.
Okay. If then, two direct questions. Can, in your view, can it be the case that the Minister could simply take a policy decision to introduce referral to treatment?
The Minister could take a policy decision to introduce referral to treatment.
Okay.
But
And it goes back to this point, which is my second question.
yes,
Then, in relation to the board, your paper had indicated that the demand capacity estimation was £61 million. You know, given the benefits, the long-term benefits, given, you know, the human cost, the length of time that people are waiting, why is the department not considering that as a priority?
you want to explain what the 61 is first?
Well, yeah, the 61 million, and these numbers obviously move. We're talking about tens of thousands of patients. There is a cost associated with the delivery of care, associated with the gap today between demand and capacity, and that cost varies according to whether you delivered that activity through the 5 trusts within Northern Ireland or whether you delivered that activity through the independent sector. So there's a cost for that, but the issue that would be important for the committee to understand is we've done this before. As I said when I was here the time before last, you know, we have a track record of delivery. But this is not from where we are now. We're back to where we were in 2005. You know, patients waiting much longer than a year just for an initial assessment, for a routine assessment following GP referral. This will not be a thing that we can just fix by March 2016. It will take 3 or 4 years minimum to get this back to anything that looks remotely like the sort of service that we would wish to have for the population of Northern Ireland in terms of timely access to see a consultant when they need to see a consultant and to get an inpatient or day case procedure when they need to get that.
But you've talked in terms of this, the benefits of this, and you said yourself you would introduce referral to treatment. But I'm still not clear, because you haven't answered why then would the department not prioritise this? Why would the department not say this is a priority?
Well, there's two separate things with respect, Chair. There's the prioritisation of the concept of a referral to treatment target. And by all means, if we had an end point in place, say in 2020, which was that no patient would wait longer from referral to treatment than, say, 20 weeks or whatever, insert time period of choice, then as part of a process to get to that, by all means introduce it. But there would be no value at all in introducing the concept of a referral to treatment target with the target itself being undefined, without all the hard bit of this is not the target.
In terms of the reduction of waiting times for elective care, then
Yes.
why is that not a priority for the department, or is it likely to become one?
It is a priority for the department, but the department has numbers of priorities and it has financial commitments. And you know, as we discussed at the budget 2015-16 session, there was a gap of 31 million, which is still a funding gap. That was and remains. We have consistently relied on in-year monitoring to supplement our funding. Whether or not we get any funding this year is in doubt, and therefore, you know, we have to cut our cloth and share the money out among different priorities. And elective care is one of a number of priorities. EYC is a priority, unscheduled care is a priority, you know, and yet we are sitting here in a position in terms of our budget for this year where new nice drugs that come on stream in 15-16, we do not have the funding to provide those. You know, and providing new nice drugs would be a priority for us. You know, but yet we do not have the money to fund these. So we are, you know, in a very difficult position where there are very difficult decisions here, and we have to balance all of these competing things. And I think in terms of elective care, you know, there's the core capacity aspect, and there's 31 million has been going in recurrently in 2015-16 to help the core capacity aspect. But you know, we need recurrent funding, sustainable level of funding on an ongoing basis, which will allow us to develop and maintain the appropriate level of core capacity and sustain that going forward in the medium to long term. And we just don't have that at the minute because of primarily resource constraints and primarily because of the heavy reliance on in-year monitoring.
Okay, but if somebody was to ask you, name your top 3 priorities in relation to transforming your care, what would they be?
I'm not sure that I would be best placed to name that, you know, in terms of the minister, but
Well,
I don't know.
the
I mean,
board and the
we've mentioned the importance of TYC in terms of keeping the population healthy, keeping the population healthy in the community, and providing care in the community.
TYC is your overarching policy, but so
Yeah.
what's the 3 key pieces that need to fall underneath that?
If you ask me what keeps me awake at night, maybe, rather than sort of thinking the minister's priorities, it's the elective care waiting lists, it's community care, and the other one would be unscheduled care.
So it's elective
Those
care
would be the
waiting
3
list,
things in my...
care waiting list, but we're saying we don't have a policy direction, or we
No,
don't.
I'm not sure that we are saying that. I think what everyone is saying, and I imagine what most people around the committee table would say, would be we would all wish that we had a position that the population of Northern Ireland was not waiting an unreasonable period of time to be assessed, diagnosed or treated. And as far as that is a policy position, it is a priority for the department, it is a priority for the board. There's simply no, you know, Deborah just gave an example there of the reality of the situation now. So new NICE drugs, if a new NICE drug is introduced in July 2015 for the treatment of cancer, as it stands at the minute with the budget settlement that we have, there is no funding for that in Northern Ireland. So it is, and I only make that point to highlight the starkness. It's not as though we're sitting on all sorts of soft opportunities to spend money differently, that we could prioritise the several tens of millions that would be required towards this. It's simply the stark reality of where we are. Every sofa has had its hand put down the back of it. Every pair of trousers has been shaken out, and we're still not at a balanced position yet.
I absolutely accept the constraints, but I do go back to the point, because the document, the briefing paper itself said there's no overarching policy direction. So there is an issue there. So who's in charge of policy then? Maybe answer that. Who sets it?
In terms of policy, it's obviously set by the department, and we obviously have, and the minister sets the policy.
Okay.
And you know, in terms of elective care, reducing waiting lists is a priority. And you know, in terms of, I accept that, and it's mentioned further on in one of the further recommendations, that we need a plan to move away from the reliance on the independent sector. And you know, the plan, to my mind, and Dina will comment on this, is that we have been building up the core capacity. We need to look at what more we need to do to build up core capacity, but that of itself will cost resource. And we'll have constraints in terms of maybe needing new theatres and things. We also then, in parallel, you know, need to get to a position where we have a sustainable elective care performance going forward, instead of this sort of up-down, here's some money in year for you to do it. You know, so we need certainty and assurance in terms of going forward, in terms of having a plan that we can see in 5 years' time. We have a budget, we know what we've got for the next 5 years. Nobody's going to take our money away. We might not get any more, but nobody's going to take it away. And here's where we're going to get to, and here's the steps we're going to take. At the minute, we seem to be, you know, because of the budget position, we're seesawing between here's some money, because we can't move forward without the money at this point in time. And if you're not getting certainty in your funding going forward, you are on this constant seesaw.
But you see, I go back, and I'm going to finish on this point, to, you know, some of the evidence that we've taken in this committee over recent time from various sectors, and including academics, who've actually said that the separation of the policy versus the budget allocation is frightening. I think disturbing was the word was used. So I go back to the point was, if we know what the overarching policy is, what's the key planks that sit underneath them? They become protected in order to deliver the policy. So I don't get the fact that we've TYC, the reduction of elective care, waiting times for elective care is part of that, is connected to that, and yet we're saying we've no policy for it. And now we've no plan to do that.
We obviously have a policy to reduce elective care, and there's continuing work going on to reduce elective care waiting times and to enhance the core capacity, and that has been seen coming through. But I suppose in terms of the overall position, in terms of how resources are allocated, yes, resources are allocated, but we have to meet our contractual commitments first, and then you're into, well, okay, what's left and how do we share this out to keep all of the to keep the priorities going forward? Because if we go to turn off a tap in one place, inevitably to give it somewhere else, that's the stage you're at in terms of turning off the tap. And I suppose that's maybe part of the wider discussion in terms of how we deliver services as well. And in terms of how we reconfigure services, and that's part of the sort of the wider debate on the Donaldson issues, which are out to consultation at the minute. So there, but at the minute, in terms of policy, the policy's there. The policy, whenever decisions are being made in the Commission on Plan Direction, they are linked back to priorities in terms of Quality 2020 and TYC and so on, and you can see the links coming through there. So there is a connection there. But I suppose your question is, well, if those are your top three, give the money to the top three, if you know what I mean, in terms of if it is elective care, unscheduled care and care in the community, give the money to the top three.
It's not about turning the tap off, it's about where the tap needs to be directed to.
Well, inevitably that means you have to turn it off somewhere else.
Okay, look, there's a number of members have indicated. Fergal first.
Oh, yes, thank you for your presentation. I'm just want to get into some of the thinking behind the work that you've done, and I think the clue comes for me anyway in the first page, paragraph 3 at the end of that officials would review the experience of other parts of the UK in introducing RTT targets to better understand the scale of investment required and potential benefits to determine whether such an investment could be justified. So can you take me through that, because I get the sense that you changed the goalpost from what the committee was saying into a financial argument.
If I can respond on that, the approach that we were taking was to look at the experience of England, Scotland and Wales in terms of each area had introduced a referral to treatment targets, and working back to the very source in terms of how they did that, how they planned for it and how they delivered it. So the starting point in terms of where the targets themselves came from was actually from their policy documents.
Yes, but that's not what in this first paragraph on progress, no commitment was given at the time to the introduction of such targets by the Minister. But then you went on to reference it through what the scale of investment would require, as opposed to a core analysis of what the value of RTT is.
We know what the value of RTT is. We know it basically is a better way to measure elective waiting times because it gives you a complete picture of patient waits. It means a patient is actually tracked through the hospital system, so we know where they are, and it also reduces clinical risk.
Yes, but when I'm reading this, I get this as an argument, if you like, of a justification for not doing.
No, I wouldn't agree with that. I was coming at it from, completely open-minded to say, okay, what did they do in England, Scotland and Wales to introduce it? And the question in my mind is, can we do the same here? Mm-hmm. And that's why...
But you see, the reality is we won't arrive at new directions and different strategies unless we argue for them. And if we're referencing it through simply saying we don't have the money, then we won't go there.
Would it be fair to say, Alison, that the Department is absolutely supportive of the principle of introducing a referral to treatment target?
Yes, absolutely.
Ministers on record.
If we could, we would.
So
I think
committed, yes. That position is clear. It's just that, but there's no point in pursuing that unless we...
Well, this is where we would differ.
Okay.
I think there is a point in going there, because if you don't argue for it, then it sits on the shelf as something not being done. Whereas we need to present in all of the what would be the right way to do it, because of course I understand that there's financial constraint, but that's if you understand where I'm coming
No, I
from,
do.
that's there.
But perhaps the nuance on that, though, is that there would be no, and maybe to describe it more clearly, from my point of view, I see no value at all in doing it unless it's part of a wider plan to reduce waiting times. If it's part of a wider plan to reduce waiting times, and in the way that Deborah's described, that it's appropriately resourced with sufficient certainty over a sufficiently long period of time, then absolutely it's the right thing to do, but not on its own.
And actually, this infects some of the conversation that we'll have later on about workforce planning and data, for example, and understanding what the flows are through the system. So we're looking at bits and pieces of the problem, referencing it through lack of finance, and that's a blockage. That becomes a blockage in the thinking as I see it. Whereas I would have preferred to see a document which is saying we accept, or wherever the provisions. In the end, we've ended up with the answer is no, because of the money. Whereas we should have an argument advanced. The argument should be about yes, because it's the right thing to do, and it's the right thing to do in the context of X, Y, and Z. That's the document that I would like to have seen, notwithstanding the fact that we don't have the money there. Because there could be arguments elsewhere and could be discussions elsewhere about how potentially we would resource that.
And I believe,
So in other words, how do we get our thinking onto that positive track? Not vainly positive, I urge you to understand, but the absolutely right and appropriate thing to do within a well-run health service. That's what you would do. And at least that gives strength to the politicians to be able to argue the case for the money you need. But I don't have that here.
Well, I mean, what, if I can just say in terms of what was set out in that briefing paper, it's almost like a roadmap in terms of if we were to go down that road here in terms of introducing a referral to treatment target, what we would need to do, looking at the experience, England, Scotland and Wales, and the first thing you need to work out how you were going to deliver it. You'd need to be able to afford to do it in terms of delivering the extra investment you need to deliver the extra activity. And then, even in introducing a referral to treatment target and getting the waiting times down, you have to be able to maintain that. So in other words, you have to be in a position where you have sufficient ability to maintain your capacity against your demand.
Yes. But the document that I would like to have seen, which should be one that suggests what best practice would be against what we have, that gives me an argument for making a case. I don't have an argument for making a case. Well, on the money potentially.
Thousands of weights. That's a good argument.
Well, it's another argument. But then, then all we get hit with then through the chair is we have no money,
Well, that's a budget question.
and that's a budget
And that's
question.
the
But none of this
Assembly
moves us forward.
voting the
Sorry.
budget.
Okay.
Okay, go ahead, Fergal, sorry.
well, I apologise if it's not clear in the paper that the department's
Not about apologising.
supportive of the
It's not
concept
about
of
apologising,
RTT. I
Deborah.
suppose it's the journey and the constraint at the minute. You're quite right. The destination, our destination, we would absolutely agree with you. The destination is referral to treat target. The difficulty at the minute is really, it's not even to my mind the IT systems. It's, you know, that's something that we can work at, and you know, we are working at joining up IT systems, and the electronic care record is an example of that. The e-referrals is an example of that, and our aspiration beyond 2020 is that we would have a single system for your you know, electronic health, you know, that follows you as a patient, and it's a single system. The minute the e-health, the e-care record is an aggregation of multiple systems, but our aspiration is that we would have a single system. When we would be looking at that single system, and indeed when we're looking at our current systems and trying to link them at the minute, we're very conscious of the need to link the data, and we're looking at the metadata, and part and parcel of that would very much, even just doing that work, would help us from an IT perspective in terms of referral to treat target, you know, in terms of having the data available. So, you know, I wouldn't like you to think that we're sitting here thinking we're not doing anything in our IT systems at all that might help this agenda. I suppose it's back to the point that in terms of the destination, absolutely agree, is a refer to treat target. It's realistically at this point in time, you know, that piece around here's where we are at the minute. Going back to the sort of discussions whenever it was discussed back in 2008, and it was agreed not to introduce it at that time as a PSA target, simply because of the difficult resource position at that time. I mean, we're in a worse resource position at this time. Now, whether the destination would have been right and got you there,
Yeah, but that's back to the argument where we say, where does this fit in as a strategic priority? And I accept it fits in with other strategic priorities, but at least if we have it as this is a gold standard, that's where we need to go to, and that's what I'd like to have seen. And then there's one paragraph at the end, but we don't have the money. But at least the substantive material should be about what is gold standard and what we should be aiming for.
No, agree.
Thank you, Chair.
Okay, thank you. Michael?
Right, okay, just to follow on that, because we do already have standards that are set, and that's about first outpatients, about diagnostics, and then inpatient. And we used to talk about 9913, which was the travel time, which is your referral to treatment, when you add them all up. Where are we now with that? It used to be, I think it was 65% or something at various weights. Because I think it's get us an indication of where the system is at the minute. Because it seems to me that if we're not in an emergency situation, we're getting close to it. We have huge weights here, right across many specialities, and I now understand we're developing weights in and around cancers as well. So that would obviously major concerns. So what I think we have to do, the first thing we have to do is stabilise the system. Get the system as it's sitting stabilised rather than deteriorating. And you're talking about going back to 2005 and weights. So we have a situation where we're going to hear from BMA in a minute, but very serious concerns there about number of GPs available. We had the Minister here in June, Chair, if you remember, telling us that last year 50 graduate doctors went off to Australia and Canada. And I mean, we can't sustain doctors working with their feet, voting with their feet. We can't sustain that sort of punishment. We have had industrial action now recently for the first time in living memory. And I mean, that gives an indication of where staff morale is and where staff think we are. And patients and patient-client council provide us with a similar story. So what we need to do is stabilise the system and do it quickly. How do we do that? What are the steps that need to be taken? How do you get back to your 9913 or whatever your current standards are? They're set every year. I don't know where exactly they are at the minute. How do we do that? What do you need to do that? Because what actually has to happen here is parties surrounding the table at the executive have to agree a reallocation. We need emergency money into the health service.
Yes, if you want to maybe pick up on the election.
Well, you mentioned, Mr. McGimpsey, the 9, 9 and 13. I have, just because I thought it might be interesting for members to see what these are unvalidated figures for the end of March. So again, usual health warnings around them, that they'll be refined going forward. At the end of March, there were over 100,000 people in Northern Ireland waiting more than 9 weeks for an outpatient appointment. There were 28,000 people, again unvalidated, at the end of March waiting for inpatient or day case treatment. That is approximately half of the total number of inpatient and day case waiters of 58,000, and quite a lot more than half of the total outpatient waiters of 188,000. In terms of whether the system's in balance or not, the system, so we're going into next year with that. We came into this year with that as our starting position. So already 100,000 outpatients waiting longer than a reasonable period of time, and 28,000 inpatients and day cases waiting longer than 13 weeks. The gap between funded capacity within trusts and expected demand for next year is about 60,000 outpatients and about 16,000 treatments. So those numbers only go one way during the year in the context of the funding that is available. The impact you alluded yourself, or referenced yourself, excuse me, the potential knock-on impacts. The main impact is for patients who are waiting for routine assessment or routine treatment assessed in that way. It may not feel routine for them, I'm sure, if they're a routine hip replacement, as it might be described, would not be for many of us around the table in any way routine. It's people waiting in a lot of pain and all the rest of it. But the main impact is on those patients. But inevitably, there begins to be creep. It starts to wander in towards the more urgent categories, particularly in those specialties where there is the greatest pressure on them. In terms of the solution to all of this, the short-term solution would be exactly as you say. There has to be a degree to which we, at the very least, get a degree of stability back into the system. That would be in part by funding additional non-recurrent activity within trusts during the year, would be in part by funding additional independent sector work during the year, but that will not be switch-onable at a moment's notice either. That has been, as the committee is aware, turned off now, with the exception of a very small number of patients that were already out in the independent sector since September of last year. But to get a degree of control back into the system, and then gradually, as I've said, as part of a wider plan where we have certainty around funding, joining up the dots on the capital budget in terms of additional theatre capacity, on the staffing budget where it's very problematic for the department to lead on workforce planning to expand the workforce at all, that's just not happening at the minute, but that we have a plan that joins up all of the dots of this to land something in 3, 4, 5 years' time where the combination of short-term additional investments within trusts non-recurrently plus further investment in the independent sector allows time for that additional investment within trusts to come over the hill and the system to be in balance, and delivering the short waiting times that we would all wish to have delivered. But from where we are now, it is not, and I would not be delivering what you would expect of me if I leave you in any doubt that this is that we receive X million pounds in June monitoring and I can have this with colleagues sorted by Christmas. It has got far too far away from that. This is years of work between 2005 and 2010 to reduce the number of waiters. Again, I thought it might be interesting for today. In March 06, there were 180,000 patients waiting on the outpatient list in total. That had reduced to 68,000 by March 09. That's back up to 188,000 now. In March 09, there were 488 patients waiting more than 9 weeks for assessment. As I say, the unvalidated numbers are that's over 100,000 now. In March 09, there were 387 patients waiting more than 13 weeks for treatment. Again, the unvalidated numbers are there's 27,000. That's what I mean about the challenge of this. This is not, a £500,000 reprioritisation. Even if we were between ourselves and working with the department and the trust to identify those things from maternity or children at risk or unscheduled care or that we would see as a low priority that we could switch off, even if we could do that, it will be at the margins. This is a several tens of millions over a sustainable period of time. All these numbers hopefully give you some reassurance. And again, as I said at the session before last, we can do this. I'm absolutely confident we can do this. But we can't do it when we're going from hand to mouth on the resource side of things. There needs to be additional resources with certainty around that for a sustained period of time.
We did it before, and we can do it again, but it's very expensive. You need is to get some sort of sense of what size the emergency fund needs to be in order to get yourself back onto a stable, and what's the time frame of 1 year, 2 years, 3 years. And I know this can't be done overnight because I was there when all this was going on before, and the way things have changed. There are other issues that are floating about, and I've just alluded to them. It's workforce morale and the situation within the workforce. It's also the situation within primary care, situation within community care. And when we're looking at transforming your care, if primary care isn't right and community care isn't right, it's very hard to see how you get transforming your care to work. It's to get some notion of, because the health service, health and social care, has been seriously underfunded over the last few years, how do we get that back? What's the amount that we actually need in terms of money? Because that's what everybody understands. And you must have a notion. I'm not saying just do it now, tell us now, but I think you need to come back to us with some sort of step-by-step in terms of what you need. And I'm just talking about stabilising. I'm not talking about gold standards and Rolls Royces and all the rest, but we'll get all those in due course.
Well, I guess there's two separate things. Mr. Mergimsey, there is the wider resource context you alluded to there. If the question, I'm happy to provide what that might look like, but the more immediate thing around this, again, if it would be helpful, and departmental colleagues were happy enough. we could produce something that would look like and ties back into the referral to treatment discussion and all the rest of it, as to a phased, costed, deliverable plan to get from where we are now to some reasonable endpoint over a reasonable period of
We all
time.
understand that's just one step. There's lots more needs to be done. And you keep referring to transforming your care, and that's primary care, community care. But it's just to get this immediate, which is where all of us get pressure from constituents, family members in pain and distress, possibly coming to harm because they're not getting the treatment they should be getting at the time they should be getting it.
Chair, may I make just a point in it, and it's picking up on some of the issues that you raised. We've obviously focused on, the roadmap that you would maybe have in place to better improve elective care, stabilise it and get to a standard, and then, aspire to the refer to treat target. But in terms of the whole system, we know that, what happens in elective care can get knocked off track by what happens in unscheduled care, and what happens in unscheduled care can get knocked off track by what happens in primary and community care. So, in terms of the holistic piece, it's that holistic piece as well we would need to have sight of. So it's not just a simple fix in terms of, throw a lot of money at elective care. We would also need to look at what we need to do. What do we need to invest in community care? What do we need to invest in primary care as well? Just as examples. So there's not, it's not just a silo piece of just throw it all in there, because
but you need
it
to
will knock off track.
stabilise this system.
You do need to
because
stabilise.
every month your weights are getting bigger and bigger and bigger, and you don't have the capacity in the system to fix it. You need the independent sector to help you. So that's about pressing that button and getting that rolling again. And that's just one.
On priming, yeah, go for that.
Okay, thank you, Michael. Joanne?
Thank you, Chair. Just following on from Michael's comments, and I've been writing down some of your comments and Michael's. We're getting close to emergency situation, and I know, suppose Michael touched on it as well with workforce morale. I know with election in full swing and chatting to people in the doors, I have been astounded by the amount of community staff or nurses are out there, doctors that are literally at breaking point. They're in tears in the doors. The morale is the lowest it's just unbelievable when you're knocking the doors, and that's unsustainable because they can't cope with that amount of pressure, and they're almost feeling guilty that they can't cope with that amount of pressure. So it is a ticking time bomb, and it's right up there with one of the biggest issues that we are hearing, and something needs to be done, and needs to be done sooner rather than later. Appreciate your honesty, then. You refer to it. The figures that you have released there are startling and they're alarming to hear. And as Michael said, we need to stabilise the system. We need to do it quickly because we're just running out of time here. And these are people's lives that we're talking about. Suppose in all of this, I'm thinking what cost is given to the pain cost with those people. I've had so many constituents that their life is effectively on hold if they're told 10 months for a new hip, and the pain that they are under and the pain all their family are under. So they can't return to work. There's the cost implications for the Northern Ireland economy as a whole when these people are out of work and in terrible, terrible pain. So how do you factor that in? That, that's, we're talking about budgets here, but those pain that those people are enduring and the financial cost. I'm very concerned the fact this is having in the economy as a whole. Suppose you've touched on as well the cost of surgery been taken in other regions of the UK, and I know that's sort of been wound down to a certain extent, and Michael has alluded to that using maybe external services as well. But I'm thinking Scotland as an example with that. The cost of the families going over there with their loved one when they're waiting in surgery, because they're unable to make surgical demand here. So that cost of sending someone over to Scotland far outweighs the cost that you could do it here. So what realistically are you doing to address this, to think, hold on here, people waiting months in agony? This can't go on. The workforce under pressure certainly can't go on, and I know I'll be hearing tonight again on the doors. And to see people that we rely on at breaking point and in tears, just it's too much. and the strain on the families. Can you allude a wee bit more onto that, or what?
I can't. Well, I suppose in terms of what is being done today, the budget is an issue of live discussion still. It's, as I understand it, and I'm reasonably close to the detail of those discussions, it's not a final position yet. There's still detail being worked through between the department and relevant stakeholder bodies, ours included. We only, in the second half of the year, spent a very small amount of money in the independent sector, and nearly all of that was in Northern Ireland anyway. So there are always going to be patients going across to GB, but they tend to be, in the vast majority of cases, for things that we can't straightforwardly do in Northern Ireland, even in the statutory sector within Northern Ireland. Some of the more complex kids procedures, some of the more complex adults procedures, and so on. So the cost of that sort of is the cost for that. But I think the point you make in terms of the disruption on family lives having to go across the water, and obviously all of those points are made around the paediatric cardiac surgery.
Yes, the very young or the more
That's
complex.
right. Having said that, though, I think if you asked any of the thousands of patients currently waiting and gave them the choice between having their hip replacement in Blackpool next week or waiting in Northern Ireland to get it in 2017 or something.
Of course, anyone would take.
I think I know what the answer for many of them would be, which comes back to that. And it was the same issues we faced back in 2006, 7, 8, 9. And people voted with their feet. No one was forced back then to be treated by any particular provider. But for the vast majority of people, for I'm sure most of our family members, whilst you might ideally prefer to have care locally to the required standard, if that's just not possible, you'll take it across the water
But the
or in the
cost
Republic
of
of Ireland.
sending, when it can be done. How?
If that is a straightforward choice, and what I was going to make is I wouldn't ask a patient to go across the water if it could be done
here. Yeah.
So you put to this required quality standards and all the rest of it. I think in terms of the pain issue, again, you will all know that from your own, particularly at this time and with the election and so on. You will know that. You've said that yourself in terms of what people are saying to you. We certainly know that. I know that on a day-to-day basis in terms of being out and in the service and speaking to patients. But we know it more immediately from family members and so on. We will probably all have relatives around the table who had reason to have an orthopaedic procedure or whatever else. That's why, with some authority, having had direct experience of a family member, I know what that looks like, because I had a family member who's been on both sides of that 2005-6 divide. They've been on the side of the divide when they waited for the left knee 3 to 4 years from GP referral to having it treated, and the right knee, the referral all the way through to the treatment was less than 6 months. That's the difference. And you cannot put a price on that. That just sounds like Mrs. Smith needs a knee replacement. Mrs. Smith has not got to the stage that a surgeon is replacing her knee because it's a bit of a twinge. Mrs. Smith can barely walk on her right knee is the problem, and that's the place that we're in. And the consultants and GPs and nurses and other professionals, because far more than I are seeing this on a day-to-day basis. They're the individuals having to say to people what the waiting times are going to be. While some people may be able to buy their own procedure, that's very much the exception in the Northern Ireland context, and that's not what we're about in the HSE. We're about free at the point of use, reasonable waiting times for everybody. It's just not possible within the resources that we have available to us. But I think to not leave the discussion in too downbeat a fashion, but I think it is a very grave position that we're in. If we were sitting here today, as we might have been perhaps 10 years ago, not really having any idea as to whether we could fix it or not, we know that we can now. So we had long waiting times in Northern Ireland for over 10 years with no prospect of them being fixed. We showed before that we can turn things around with a really concerted effort involving everyone from the Minister, Health Committee, Department, commissioners and providers and primary care. We can turn it around, but it won't be a little nudge at the side. It's a top of the shop. You can all insert your adjectives of choice around this, but it will require top of the shop direction and prioritisation to get this to where it needs to get to.
It's just in the meantime, it's so dire out there, the workforce morale. It is, when you have people crying on the doorsteps and wanting to remain anonymous, but they care so much for their patients, and when someone goes off
Right, folks, I'm going to, just because I am very conscious that we're not here to reflect an election campaign or what's coming on the doorstep. I think we need to be very mindful, but I think we need to be very mindful. I think we're all well aware of the pain that people are enduring in relation to this issue, and I'm attempting to be positive on this, Dean, as well, and I'm hearing you saying we need a top-of-the-shop approach. Are we suggesting we don't?
No.
And when can we see that top-of-the-shop approach to delivering on this issue?
I suppose I maybe have a little bit more freedom than departmental colleagues have in this regard, Chair. By top of the shop, I mean, and I think you've alluded to it yourselves, I've said we are doing this is a priority for the department, this is a priority for the board, this is a priority for trust. Fact. It has been for donkey's years. It remains a top priority for us. But the resources that we have means that there's plenty of other priorities, new nice drugs being one, that can't be funded either. So when I say top of the shop, and I hope I'm not speaking out of turn, I mean top of the shop. I mean it's a priority for right the way through to the executive to consider prioritisation of funding towards health. And I know exactly the same challenges there as well in terms of the competing priorities on very scarce resources. But within, happy that someone else will reach a view that more could be done within the resource that we have. But my view, on the basis of the resource that we have today, we are not even remotely close to being able to turn this around in the way that we would all expect it to be turned around. Yeah,
but at what point are we going to see, at what point are we going to see the roadmap that Michael and others have referred to?
Well,
at what point will you demonstrate to us, you're saying this is a priority area, this is a priority policy area. When will we see the demonstration of getting to that destination that yourselves have spoke about?
Well, from my perspective, Chair, in the resource context that we face now and into the future, I'm certainly happy to work with departmental colleagues in picking up the important issues that Deborah talked about, to share with you what the resource requirements, what a roadmap might look like, what the interactions with other service areas might be and the assumptions might be. And what the resource requirements of that would be. But it needs to be resourced. And I'm saying that from my perspective, it is impossible within the current resource settlement to resource something on that scale. There was a very different resource context back in 2005, 6 and through the years. Then it was much more benign than it is now.
We can certainly work on a roadmap over the next couple of months in terms of that, because there are so many different strands to it, and see what we can come back to. So we can take it back to the Minister, and see how we can prioritise and the roadmap piece.
Bring that back to yourself. George, I think I'd indicated.
Thank you, Chair. I really appreciate the situation that the officials are alluding to from a financial point of view, and suppose you still have to look back and think that a few years ago there's a 1.4 billion cut in the block grant, and we're just beginning now to see some of the consequences of that. And as well as that, we've got the welfare reform issue. We're losing about 2 million every week in fines and so forth. So there's bound to be a knock-on effect somewhere. And unfortunately, as Joanne has mentioned, there's people out there suffering. And at the same time, I don't want to turn this into an election meeting either. But we have to be all realistic that there is pain, there is cuts, and it's just how we manage it all at the present time. And the officials here have been very candid, very frank, and very, very honest with us. And it's something that we all, as all the parties together, has to work on as far as the Assembly is concerned. And the big one for me at the present time is obviously welfare reform. And the longer that's not, we go along without implementation of welfare reform, the more pain, which Joanne has alluded to, we're going to get on the doorsteps. Mine is more a comment than any questions, but As I say, we have to be candid, we have to be honest, we have to be frank. And that's what we all need to be gearing for ourselves up for at the present time.
Okay, Rosie had indicated.
Okay, Graham Carly. Can I just sort of refer back to you were mentioning earlier about people having to cross the water to get treatment. What percentage of people have to go overseas to get the treatment? Trying to look at it in terms of what sort of drain is that in resources, because there's that aspect, and there's the aspect of the implications and the impact on people who are suffering already.
In terms of if there's patients going across for treatment because we physically can't provide the treatment in Northern Ireland, as I say, a lot of the issues associated with that were rehearsed through the paediatric cardiac surgery consultation. So where we can't safely and sustainably deliver a service within Northern Ireland because of our population of 1.8 million, then it's entirely appropriate that we would seek to commission that service from a provider that does meet all of the extant quality requirements. The vast majority of any patients who are going across the water in that context, it would be in the context of the numbers we're talking about today anyway, it would be vanishingly small. Even when the spending in the independent sector was at the sort of levels that it had been historically, around £60 million a year, even then, when we were, and most of that was being spent within Northern Ireland, even that as a percentage of total acute spend was only 3 or 4% of total acute spend. So it would be, to reassure members, it would be vanishingly small. I can certainly get, I can, because we keep records of all of the transfers across the water, I can certainly get you details of that. But what I would say is I would be surprised if more than a handful of those patients in the last year had been sent across the water for reasons other than the care that they required simply wasn't available straightforwardly within Northern Ireland. It wasn't because the waiting times were too long or anything like that. It was simply that they required a particular type of access to a specialist or access to a particular treatment that wasn't available in Northern Ireland.
So those wouldn't be cases where you would foresee creating a capacity to deal with here. It's better use of resources to take people across.
Most of the time, that's right. But over time, what we look for though is there are some things. There's a couple of issues around at the minute where initially we send the patients across the water, but then over time we see opportunities to actually, if there's sufficient critical mass, to actually put in place, that there is the opportunity to put in place a safe service locally. But for the vast majority of cases, yes, you're right.
The knee operation then you were talking about, was that an exception then, because knee operations are carried out here?
Well, the knee that's going back several years now. Back in the day, we were sending patients across the water because we had capacity constraints within Northern Ireland, but certainly in the last 6 months there won't have been any patients like that. All of the patients that were seen in the independent sector were in local independent sector providers, so we haven't been sending any patients at all away.
Okay, I was just trying to get a sense if that was a resource issue, but it clearly isn't really, from what you're saying.
But going forward, back to the plan that we subject to discussion with Deborah and colleagues that we might be sharing with you, that may include elements of accessing independent sector or other NHS capacity outside of Northern Ireland. But we would need to work through the detail of that to get us to a sustainable position.
Priming sort of thing in advance of establishing sustainable long-term capacity. Might need to do that to pump prime, step us up. Yeah,
I think the department and the board's position is clear on this. I have no desire to use the independent sector any more than is necessary as a short-term response to particular capacity demand pressures. But from where we are today, at the end of March 2015, theoretically you could avoid using the independent sector going forward, but you would be doubling, trebling, if not longer, the length of time to get things back into the sort of place you want, because there simply isn't the workforce within Northern Ireland. Urology would be the example I often trot out, where we continue to have huge difficulties in that and other areas, just recruiting the staff The money may be there. We can get the anaesthetists, we can get the nurses, we can secure other key members of the professional team. But if we can't get all of the members of the professional team, we can't expand outpatient capacity and treatment capacity.
All right, thank you.
But would you accept just on that sometimes the approach of simply putting money under the private or independent sector hasn't resolved the issue?
But it depends what issue it is we're seeking to
Well,
resolve.
we're talking
Chair.
about waiting times for elective care.
With respect, it has reduced. If I'm a patient waiting for a hip replacement and I go to the independent sector and I get my hip replaced, I would argue it has resolved that issue.
Yes, yeah.
What it hasn't done is to put in place a sustainable increase in capacity within Northern Ireland. But it's certainly nothing I am investing as straightforwardly and have been investing as straightforwardly as I can do within trusts in Northern Ireland, where I am confident and they are confident that they can expand their capacity within all of the constraints I've talked about. If they don't think they've got the extra theatre capacity that they need, or they don't think they can appoint the consultant staff that they need, why would they wish to take the money for capacity they won't be able to
Has there
deliver?
ever been, have the auditor's office ever looked at this in terms of value for money? They have? Was there a piece of work completed on that then?
Yes, there was a PAC review.
Specifically on waiting times? Okay, well, I'm going to ask for access a copy of that, because I think that's an important issue around, the independent sector, the private sector will indicate that they can carry out, 5+ procedures a day, and suggest that some trusts and hospitals can carry out 2 or 3.
Chair, in my
There's a challenge in that in relation to, value for money. So in terms of the PAC work, has there been recommendations?
The PAC work, as I recall, and I mean, it'll be available straightforwardly. The PAC work, as I recall, was around the general departmental approach to the management of waiting times, and clearly part of that was around the usage of the independent sector. PAC also looked at, as part of that, DNA, CNA review rates, all of that sort of thing as well.
Predates me, which is why I'm sitting silent, because I wasn't around when they did that, but I will go back and I'll read it.
But there can be, the independent sector will argue that they can be more efficient, productive than the statutory sector. And that may be right in certain cases. They're not trying to train junior doctors, for example, at the same time. They may be doing a different case mix than the statutory sector are doing. That's why, though, we continue, where it's appropriate, to use the independent sector. It appears sometimes it's a more expensive route than putting money into the statutory sector, but often it can be 6 and 2 3s. But the committee's expressed desire is to move away from the independent sector. I'm saying that's my expressed desire too. But in the short term, if we want to turn the challenging position that I've described today around within any sort of reasonable period and with any momentum, there will be a need to access external capacity from somewhere. And if it's not from the independent sector, it will be that and the statutory sector elsewhere outside Northern Ireland.
I mean, specifically what the committee had asked to look at how you decrease spend in terms of private sector over the next 3 to 5 years, and looking at best use of in-house. That, it's not just as simple as saying take it all immediately from there. It was looking for a plan to do that. And my understanding is that was stopped, but it's some of it. I know I visited a local independent clinic just last week, and the work has started again.
No, it hasn't. To be clear, it's just the paused patients. So again, so we're clear, because there's a risk of confusion with this. There were 4,000 patients still in the independent sector back in September 2014 when the financial position for 14-15 became clear. The urgent patients within those 4,000, authorisation was given to allow them to proceed in the balance of the 14-15 year. But there was no authorisation to proceed with the non-urgent patients because we didn't have the financial cover last year. Those paused patients, the non-urgent ones, the routine ones, are now the patients being proceeded with. But there are no plans at the minute within the financial settlement, but subject to further discussion With-
Okay, I'll pick that up with you afterwards. Okay, folks, thank you. You've obviously heard the views of the committee today. I would expect, at the very least, and going forward, that we would get that roadmap clearly demonstrated. If what I'm taking at face value today is a priority in relation to the generality of the reduction of waiting times, that we would see, or we would get a demonstration of how you get there. And that you would share that with the committee as that evolves through the Minister and through the Department.
We're certainly happy to work with the board, and we'll take that back to the Minister as something to see if he'll endorse that as a priority coming back to.
Okay, thank you for your time, thank you.
Thank you.
Thank you.
Okay, members, item 7 is workforce planning in the context of TYC, with a briefing from BMA and the Royal College of GPs. Just referring members to the response from the Department following our evidence session on the 11th of March, which is page 21 of your tabled booklet. And I just want to draw your attention to a number of items. Firstly, the number of training places for 2015-16 remains at 65. And the Department states that any increase will depend on funding decisions still to be taken. Members will be aware that the Minister recently announced the 300,000 to recruit and retain GPs, and the additional money to GPs in rural areas. So I'm asking members, first of all, if you're content that we would write to the Department to ask, if this is not going towards training places, where is the 300,000 going to? And will a decision be taken on whether to increase the training places for 15-16, given that we're already 2 weeks into the financial year? So can you get agreement to do that, firstly? Also, members, just the issue of transforming your care was based on a 3% reduction of staff. The Department at the recent evidence session surprisingly suggested that it was never a target, but it was a possible implication of implementing TYC. Again, I'm seeking agreement, members, that we would write to the Department, regardless of whether it's a target or a possible implication, to ask how the figure was reached and if there is a new possible implication within the current framework. Also seeking agreement to write to the Department to ask whether it intends to open the voluntary exit scheme to the wider health and social care, and if so, how would this be coordinated with the work in relation to workforce planning? Also, on one of the issues was in terms of retraining of staff in the health trust. The Department had stated that it was unable to provide figures for retraining expenditure. I think it would be useful to gather more information from the trusts on what they're doing in relation to workforce planning. So I'm seeking agreement to write to the 5 trusts members to request details of the workforce planning that they've undertaken in support of the implementation of TYC. Finally, the membership of the Regional Workforce Planning Group. There are no professional bodies on it. I think it may be interesting to get your thoughts today, folks, from the BMA and the college's point of view, to see your views on whether that is an issue or not. Also, just seeking agreement that we would request a copy of the 2014 interim report on workforce from the Regional Workforce Planning Group, and now referring members to the tabled papers, the briefing papers, from the BMA and the College of GPs, page 31 of your pack, and the questions at page 19 of the tabled booklet. And folks, you're very welcome, and apologies for the delay in getting to you, but we have Dr. John O'Kelly, the Chair of the College of GPs, Shauna Fannin, who's a Deputy Chair, Dr. John Woods, BMA Council Chair, and Dr. Tom Black, Council Deputy Chair and Chair of BMA NIGP Committee, and you're very welcome. So I'm going to ask each of the representatives of each of your organisations to make an opening presentation. We'll open it up to comments and questions.
Thank you, Chair.
Okay.
Chair, firstly, on behalf of the College, I'd like to thank you for the invitation to address and give evidence to the committee this afternoon. We have previously met with several members of the Health Committee on an individual basis on a number of occasions and have very much appreciated the time given by you to listen to our concerns and discuss the various issues. Most of you will be well aware of the issues facing general practice in Northern Ireland at the present time. The College is the professional organisation for GPs in the United Kingdom. It has approximately 1,300 members in Northern Ireland, which is over 80% of the GP workforce. 50,000 members in total in England, Scotland, Wales and Northern Ireland, and we have over 600 members in the Republic of Ireland. General practice faces similar urgent concerns in all these countries, and the health departments in England, Scotland and Wales have begun to take action on some of them. Chair, we have provided you and your colleagues with a briefing document which I hope, together with our previous conversations, will offer an insight to the serious crisis that is emerging in general practice. The College has traditionally focused itself on the key issues of setting and developing the standards for general practice to deliver the highest possible quality of care for our patients, the training of young GPs, the further education of established GPs and research in general practice. In November 2013, it launched an unprecedented campaign, the Put Patients First Back General Practice campaign, in response to concerns for the future of general practice and the delivery of care to our patients. The campaign calls for an increase in the percentage of the NHS budget allocated to general practice to 11% in order to reverse the trend of disinvestment and allow GPs to continue delivering high-quality care. This is in the context of the increasing needs of our population, significant rises in consultation numbers, the movement of care to the community, and the increasing complexity and number of medical conditions that our ageing population will develop. As you are aware, we have a serious crisis emerging in the GP workforce which can no longer be ignored. Morale is at an all-time low. In Northern Ireland, we have the lowest number of GPs per head of the population in the United Kingdom at 6.4 per 10,000. The oldest GP workforce, with 24% of our GPs over the age of 55, and an ageing practice nurse population. Insufficient numbers of young doctors are being trained as general practitioners. And in addition, we have real problems in the retention of GPs. Chair, there have been 3 workforce reviews since 2006, with each highlighting the need to increase the number of GPs. It is with dismay that the College notes that there has been no action taken on the recommendation of these reviews. Each one has highlighted the urgent need to increase the number of general practitioners in the workforce. The 2014 interim report on the GP medical workforce said, "There is material evidence that a shortage of GPs available to the medical workforce is having a detrimental impact upon the delivery of GMS in Northern Ireland. There is a further likely consequence in that this will undermine any attempts to deliver a shift-left commissioning policy, moving service provision from secondary to primary care." It recommended that the number of GP training places in Northern Ireland should be increased to 111 annually, phased over 4 years, with an initial target to increase the number by 15 for commencement by August 2015, but implemented no later than August 16. The Department of Health has pursued a policy over the last decade akin to the ostrich's head in the sand. It's time to get its head out of the sand and start dealing with the situation. Our concern is that the recommendations of the 2014 report will not be acted upon, as has happened with the previous reports. If that occurs, be in no doubt that general practice in Northern Ireland will face meltdown in the next few years, with dire consequences for our patients, especially our most vulnerable patients. We are already seeing problems with shifts in GP out of hours not being covered, with outlying centres not staffed. This will continue to deteriorate and will have knock-on effects on in-hours care and emergency departments. As GPs, we want to deliver the best possible care to our patients. Our job is complex, it's demanding, it's interesting, it's professionally rewarding, and we get great enjoyment from it. I know I can speak for Shauna and for Tom here in that we don't want to do anything else. But it is incredibly frustrating when you find that you are being constrained by circumstances outside your control. If we do not address the working environment for GPs in Northern Ireland, we will end up having a brain drain with our young and brightest doctors emigrating or taking up positions in other parts of the United Kingdom. College is calling for a new deal for general practice, with increased investment in infrastructure, support staff, that's secretarial, practice nurses, pharmacists, physiotherapists and other allied professionals. We need investment in training, increasing the numbers of GPs in training, an extension of the GP training to 4 years. We need retention and returner schemes and a greater emphasis on general practice in the Queen's University undergraduate medical course. With these measures, we believe we can turn the tide and have a profession that can continue to deliver the highest quality of care to our patients. Thank you, Chair.
Thank you. And can I hear
Yep.
from yourselves?
So good afternoon, and thank you, Chair, for the opportunity to come from BMA Northern Ireland and give evidence to the committee today about workforce planning in the context of TYC. So committee members, I think, will have received a copy of our briefing paper. I'd like to address some of the main issues within that. BMA represents doctors, all doctors delivering care to patients in both primary and secondary care in Northern Ireland, and we believe that effective medical workforce planning is essential to allow those clinicians to deliver high quality and safe care to patients. And that's why the BMA has been advocating so actively and contributing to a whole series of medical workforce reviews. And these have been done and published in 2004, 2006 and 2010. And we're involved in the current round. We advocated very strongly for the current round of reviews, and we're involved in those. And to date, those have been in paediatrics and in general practice. So Northern Ireland really has a first-class medical workforce, and I think patients rightly expect to be able to continue to access high-quality, safe care. But we believe that ineffective workforce planning really is seriously undermining that goal. And we see the consequences of a lack of effective workforce planning. And crucially, increasingly, this is impacting on patient care. And despite work done by the department to date, we really are very concerned and frustrated at the lack of progress that's been made to date. On TYC, implementation of TYC began 4 years ago, but we really have not yet seen the changes that are needed within the workforce to make the TYC vision a reality, being planned and being resourced. We haven't seen any work on that to date. So I know you're well aware that there's a major workforce practice crisis in general practice. Although this is the most obvious example, there are similar gaps in secondary care specialties as well, in emergency medicine and radiology, for example. And it's easy to see the consequences of ineffective workforce planning, and members will be well aware and have commented on the resources that have been spent on locums within secondary care to fill gaps. BMA believe that an over-reliance on locums is a very clear consequence of the failures of planning and implementation to date. So that money could and should be more effectively spent on training sufficient number of doctors in the necessary specialties. So there's a pattern of a continued failure to recognise and to adjust to the changing health needs of the population in Northern Ireland, and there's a couple of factors here. So first, we have an increasingly ageing population, and they have more complicated health needs. And I see this in my own practice as a hospital consultant. So patients are older, they're sicker, and their needs are more complex in general. And, for example, this has led to significant increases in demands for diagnostic imaging, for scanning and for x-rays. And so we now have insufficient radiologists to do those tests, and we've been hearing earlier this afternoon about the problems that that causes. And second, as Dr. Kelly alluded to, with TYC, there's a planned shift of service delivery from being predominantly hospital-based to community-based care. And that has implications for both primary and also for secondary care. And appropriate workforce planning is integral to that. And it must be properly planned and managed and resourced. And we're really concerned that this is not happening currently. So a final factor that's leading to change is the composition of the medical workforce is changing. And there has been, again, failure to act in response to those changes. So our information about the changing demographics of the medical workforce are on page 8 of your briefing paper. But one very clear trend is that there's an increasing number, an increasing proportion of female doctors. So the medical workforce, it's a dynamic situation, and there's a range of changing factors, which means it has to be a continuous, ongoing process. General practice, as Dr. Kelly suggested, really stands out as an example of a specialty demonstrating the hazards of failing to respond to those changing circumstances. And due to increasing workload, GPs are increasingly choosing to retire or to leave. And I think you will have seen the results of our survey, which have been published today, showing that a third of GPs will leave in the next 5 years, will retire in the next 5 years. So for general practice, the problems have been recognised, but the necessary action has not been taken. There's a whole series of reviews showing what the problem is. And the crisis affecting this specialty could have been averted if the recommendations in those reviews had been implemented. And one of those is the increase in the number of GP training places. It's important that action is taken soon because I'm sure as you will appreciate, the lead time in terms of training for these people is very long. From entry to medical school to qualification as a GP, it takes 10 years and it takes 14 years to train a consultant. So if we don't address the problems in workforce planning as a matter of urgency, we think that a similar problem will emerge in secondary care in the coming years, in the very near future. And this is something we care very strongly about. We've been very committed to assisting the department in this and have contributed actively to the reviews to date. But we really are frustrated at the lack of progress that has been made to date. We now understand from the evidence that was given to you in your session on March the 11th that the department is looking at a programme of care perspective for workforce planning, beginning with a pilot programme in domiciliary care. But we're concerned about this because we think it just risks further delays in resolving this issue. And this has been the problem. Things have just been pushed back and pushed back and pushed back and have not been implemented. So our recommendations are in your briefing paper on page 15. We really think it is crucial that the current workforce reviews are completed on a specialty by specialty basis as a matter of urgency, and what recommendations are made are properly resourced and are implemented. So otherwise the quality of care to patients we think will be compromised, and that's a situation that none of us want to see happen. Thank you once again for the opportunity to come and give our view to the committee. Dr. Black and I would be happy to take questions at the end.
Okay, well, thank you both. And obviously the committee shares the view that we need to refocus our health agenda, if you like, in relation to primary community care, and that does require a refocus and a rebalance and a reprioritisation of the service at primary community care. But a couple of questions, you know, and I've met with both organisations over a period of some time now. In terms of the requirement, because this is much bigger than simply saying we need an allocation of funding, there is an issue there about training, there's an issue about retention. So in terms of the training, first of all, there was a number of figures in both reports, and I think Dr. Kelly talked about 111 places by over a 4-year period. Was it 80 then by August
2015,
2015
or
or up
2016,
at the
absolute
latest? And that's a consensus with BME as well, is that correct?
You need 111 to stand still, Chair. We thought as a first step it should increase to 80. We've heard of no increase, but then this is the third report that has suggested this. Nothing about this is new. And this is about priorities. There's limited funding. This is the health service. We deal with priorities. General practice is clearly not a priority at the Department of Health. Why? Well, that's their decision. They've chosen to keep us as the lowest funded, the lowest staffed, the highest workload and lowest training numbers. This is a perfect storm. Now, the result of this perfect storm will be, and we already see this, that out of hours has collapsed in real time. You talk to your constituents, they were suffering 9 hours waits at the weekend for phone backs. That is not a service, that's a disservice. The worst thing you can do in the health service is pretend to have a service. So we've got a huge recruitment and retention problem. We have a workforce that is inadequate for the needs of the patients, and the canary in the mine is out of hours. So that has already collapsed in real time. What we'll find over the next couple of years with the failure to retain older GPs and the failure to retain the GPs that we're training is that in the next couple of years we'll probably lose another 100 GPs. We've got 950 whole-time equivalents, 2,000 patients per GP whole-time equivalent in Northern Ireland now, more than 2,000 patients. When I joined my practice, we're 1,500 patients per doc. We now have more than 2,000. We're doing 67% more workload during that time, as you've seen from our strategy document. So we have a perfect storm here, and the least you would expect is that the department would prioritise training of GPs, and they haven't. Extraordinary.
And you see, just specifically on page 13 of the BMA briefing paper, obviously the NIMDA had obviously is the body responsible, the 65 training places for general practice, 33 completed training, and that only equated to whole-time equivalent of 18 GPs.
Yeah, I mean, we haven't lost any of these trainees. They're still in the system. They may be on. They may have reverted to less than full-time training, which is part-time training in our parlance. They may have taken a maternity leave, and they will come out in time. But I mean, 2/3 of our young workforce now in general practice are female, and if they need maternity leave because of that age, you can't defer that time of your life. Then that's reasonable. But we should be taking this into account in terms of our workforce planning, and we're not. This year we'll lose, what, 80 retirements? With the survey out today that shows 35% of GPs will retire in the next 5 years, 79% of those between 55 and 59. So that's 80 we'll lose this year. If we're bringing in 30, that's a net loss of 50. So we've gone from 950 down to 900. Next year it'll be down to 850. That's collapse time. Within the next 2 years we will not be able to maintain daytime general practice. And you sit back and you think, wow, I mean, everybody at this table, Mr. Dempsey referred to it earlier, everybody at this table knows that the crisis in Northern Ireland is GP workforce. And everybody knows that that's where most of the work goes, and it's the foundation of the health service, and yet it's not a priority. And we saw the Minister announce 15 million extra coming into general practice, and I smiled, because 10 million was for premises, Michael, which is not a current account investment. It's 10 million that we are allowed to borrow now from the Bank of Ireland to build premises. So that's 5 million. Of the 5 million, 3.1 million is going into out of hours. That's excellent. Out of hours needs it because they're spending less on out of hours now than was spent in 2003. They're spending 22 million out of hours now. It was 25 million in 2003, which leaves, what's that, we're down to 1.9 million now for GMS, and that's for enhanced services, which will require extra work. The last thing GPs need is more workload. So in this very tight financial settlement that we have at the moment, not a single penny has been devoted to general practice, despite the fact we've suffered cuts for 8 years in a row. It comes down, Chair, to the basic question which you asked the previous presenters, which is, what are your priorities? And the priorities are clearly not what they said, which is community care, because district nursing has been decimated. And decimated means you lose 10%. It's actually about 20% in most areas. Mental health in the community has been decimated, and general practice. So 3 key areas in the community, all disinvested, not a priority. Extraordinary.
I think in general, yes. I mean, and that's why the committee have looked at the whole area of workforce planning, because when you do such a huge policy shift, it would seem logical and sensible that your first key area of work would be to plan your workforce. What are your workforce requirements? So that's been a key issue for us and going forward. But in terms of cost, I just want to drill down this a wee bit more. 111 places over 4 years, so 80 by August, or by the latest August 2016. Is that still costed at 90,000 per training place?
That would be 90,000 extra per place, yes. So that would cost, I think, 1.3 million.
1.35 million. So
yeah.
That's what we're talking about in terms of of the training ask.
And I think one of the other thing is that not all the young GPs that we train are necessarily going into general practice. They're not going abroad, but what is happening is a lot of them are being employed at staff grades by the trusts, but we're still losing them to general practice. And we have got to fix the environment in which general practice is working. That is absolutely key. You've got to make it a safe environment, an environment that you would want to work in.
Yeah, and just going back to Dr. Black's point as well, the 33 that completed the training, what you're saying, aren't lost to...
They're still in the system. They will come out.
Okay.
So we're not actually losing them. But as Dr. Kelly says, they come out, they look at the workload. I mean, the workload for a GP now is 47 consultations. Now, you all do surgeries. You go back to your constituencies. Would you like to do 47 this Friday? Plus 172 prescriptions, plus 35 lab tests, plus all the other stuff we do. That's the standard day's work. Now, it's taken us about 12 hours to get through that, and you go in at the weekend and catch up on your paperwork. And that's the environment we're trying to entice the young doctors into. And to be frank, what's happening is they come into general practice, they stay a year or two, they go, I have no life, I haven't seen my children for 3 days. And they go back into hospital, and the most extraordinary compliment they're paying us is they go back into hospital to A&E posts because they think it's easier. If A&E's easier, we're in trouble.
And of the, if my maths are correct, of the other 32, were they trained and left?
No, they're still in the system.
They're still.
I think
the whole 65 are still in the system.
Apparently, I spoke to the director of the training programme, and she's very clear that our attrition rate of losing them is only 1 or 2 per year. Okay. So there's 33 came out, and there are 32 still in the system that will come out.
And just in terms of contracts, because this is an issue, and just seeking your views on this around how you actually, within appropriate processes, ensure that we get the maximum in terms of GPs being able to stay and deliver for the constituents of the north of Ireland. Is that feasible? Is it doable? Can GP contracts? Can there be something written in the contract, or is it just? Are we training them up and GPs will leave?
Well, I think one of the concerns, Chair, is that you can't legally, I think, stop them from working anywhere within the EU. And I think if a young doctor is trained in general practice in Northern Ireland, and England and Scotland and Wales are producing a better environment, what I said is the brain drain, they are going to work there. We need to fix the environment in which general practitioners are working. I feel confident if we can do that, that there is enough to keep people here.
And just, I know that there's a number of members indicated, but I mean, it's obviously very frank and very strong in both your briefing papers, and correctly so, in my view. But I just noted that in the BMA's briefing paper on page 11, BMA is now calling into question the competency of the department to effectively plan for the medical workforce. That's quite a strong statement.
3 reports we've had, no action from any. You've already had department officials in front of you. I read the transcripts. I was told the video was better, but I read the transcripts. You were testing them, and quite rightly. It just comes back to my previous statement. It's extraordinary that this hasn't been actioned. To give you a history lesson, Chair, this happened in 1966 and they had to bring in a new deal for general practice. It happened in 1990, they brought in a new deal. It happened in 2004, they brought in a new deal. And in England, Simon Stevens, the Chief Executive of NHS England, is explicit in saying, we have underfunded general practice for 10 years, there will be a new deal. Now, he needs a new government in, and he will present a new deal for general practice, and he will save general practice in England. Scotland is much better funded because they like their GPs, and Northern Ireland would be very grateful if Northern Ireland Department would copy what they're going to do in England and Scotland. And Wales. Wales are in trouble too, admittedly.
Okay, and I have Paula next.
Thank you, Chair, and thank you. And I, like the Chair, I know I've met with both organisations over a period of time as well, and it's sad that we're now reached this stage and there has been no resolution has been found, and the fact, as you had said there about the RDRs, has all but collapsed.
Yeah.
And if we don't have this increase, and we do see the third retiring within, I think you said, next 5 years, was it? What's ready to collapse next? What's going to happen in reality?
Well, out of hours will go first. That will have a knock-on effect on in-hours general practice. The pressure on that with GPs going is that the list sizes will increase, which means that patients will find it difficult to get appointments. We will probably be doing firefighting. You will find that practices may have to close their lists, and you may find, and it's already happening, and Tom certainly knows this, that practices will collapse and close. And we've already had a practice in Craigavon. There are others under threat. That will have a domino effect, and everybody will then end up in the emergency department.
So that's the knock-on effect then, is then we look at our hospitals and what's going to happen there, and that's just going to be catastrophic. You know,
well,
so
the numbers, Paul, are all of the NE departments in Northern Ireland in total per year see about 650,000 attendances. GPs do 12.7 million consultations. You would need another, what's that, 90 NE departments, something like that there. It just can't happen. So the department are very well cited in this problem. They just have failed to make it a priority. When it is just about to collapse, they'll make it a priority, because they have to, because there's no alternative.
And as you said, the information you've given us again, in reality, there has to be this upload and this increase in training because of the length of time the training takes as well. So it really should have been started some time ago, as you say. It is firefighting now, and it is now got to the stage where this is the final, this is the limit, we can't go any further. This has to happen. And that's exactly where we are now. I just want to follow up on a few things, the points that the Chair had made. And we know about the brain drain. We listened to it. I listened to it again this morning on the radio across lots of different professions, and lots of our young people are being trained, and they're leaving. And my own daughter works in China. You know, our children are leaving to take their expertise to other countries as well. On the issue to do with training our doctors and our GPs and doctors in general. And I know it happens within other disciplines where we invest such a large amount of money. Do we now, going to be controversial, do we now look at where we have something written in the contracts that they must remain within Northern Ireland? What's your views on that?
No, I don't think so. I mean, I think, as John said, you know, we have to look at the environment here and why are people not choosing to stay. And, you know, people, I think, are often very reluctant to leave Northern Ireland and would like to work here if it was possible. But when they look at the opportunities elsewhere, they appear so much better. That's why they do leave. So I think it is much better to try and incentivise people to stay rather than attempt to put some sort of handcuff or restraint on them. That will not work. You know, people will find a way around it. It has to be that the working environment improves so it's attractive to work.
Okay, so that's definitely not an option in your opinion. I know it happens in other disciplines within social care,
Well, not
health
if-
and social
yes.
care. It does, because I know it happens in
Yes.
social work as well. If
So-
you're investing
so-
that money, you expect then the return.
Yeah, so not a pure restraint, but there are things you could look at. So I think about medical students is they now come out of university with very, very substantial degrees of loans.
Yeah.
£60,000 plus, and if there was some measure of debt forgiveness in that, that would be, to me, would seem a very positive thing. So there are things that you can do which aren't restraints, which are positive, which would help the situation, I think. But a pure restraint will not work.
I think also if incentives were to be used, or golden handshakes, handcuffs, whatever, is to look at areas that are under-doctored and areas where there are real problems. And one of the areas to highlight is rural general practice. And that's true throughout the United Kingdom and Ireland. Rural areas tend to be undoctored. Other areas where there are high levels of health inequalities. So I think incentivising young doctors into areas where there are a lack of doctors or where there is a high degree of need may be of benefit.
Okay, that's fine for me.
Thank you, Paula. And George?
Thank you, Chair. And, thank the people for coming here today. And in my opinion, it's been very, very useful and very helpful to hear your views. My point would be, are GPs doing any work to carry out their own workforce planning to ensure that they have enough nurses and receptionists to keep their surgeries functional?
Mr. Robinson, the funding for general practice has been decreased every year for the last 8 years. So when I hire an extra receptionist, as I did a couple of weeks ago, it comes out of my bottom line. When I hire an extra nurse, it comes out of my bottom line. If you keep cutting the funding as they have done every year for 8 years, it becomes difficult. And the problem, of course, then is that if I advertise a job which is so badly paid that people have to take a pay cut to take it, then it actually creates another problem for me in terms of recruitment.
Knock-on effect.
So I advertised a job in my nice practice in the Bogside and Derry before Christmas, and I get 0 applicants. There are 40-odd thousand GPs in the United Kingdom. I offered a full share of profits, etc., and I get 0 applicants. Why did I get 0 applicants? Not so much the money, to be frank, although any locum that might have taken the job would have had to take a pay cut of probably 25 or 30%. The reason I didn't get any applicants was because they know what the workload is like, and they won't take a job as a partner because they won't see their children. So everything comes back to workload.
Yeah.
And I think that, to follow on, going on from you, is that, yes, we do, as I said, we do need increased support of the team, the practice team. We need pharmacists working with us. We need access to physiotherapists, therapists working with us. We need our practice nurses. We do need those. And that's where, when we talk about investment, it's not just purely with GPs, but it's investment into the GP workforce and the wider community workforce. And Tom already talked about the total destruction of district nursing and health visiting.
Yeah. Just, Chair, from personal point of view, the out-of-hours practice, and where I live, in the Limavady area, we're starting to see the effects now as well. Particularly, it should be there up to about 11 o'clock at night, from say 6 until 11. And recently, that has been cut back. Maybe about 10 o'clock onwards. Some nights there is no doctor because they have to be railroaded up to Elton and Galvin, up to the out-of-hours there. So it leaves we rural areas like Limavady, they're sitting without an out-of-hours practice room.
I got a list. I asked the 4 local medical committees to do a survey of the empty shifts in out-of-hours in Limavady. As you say, Mr. Robinson, has shown up as an area, and the whole southern area has shown up in southeastern Belfast. Even pretty much all of the out-of-hours services in Northern Ireland have huge gaps in their rotas.
Yeah.
I've asked for commentary on this from the LMCs, and tomorrow I'll submit the evidence to the department and to the health board. GP out of hours in Northern Ireland is now broken, and the question I want to ask the department and the board is, what are they going to do? They've promised an increase in funding of 3.1 million on top of the 22 million they spend, but we spent 25 million on GP out of hours in 2003. Health inflation, as you know, is 6%. That means they should be spending 50 million now. If they spent the same as Scotland, they'd be spending 50 million. So again, is general practice out of hours a priority? Not for the department, it isn't.
I think, to be fair to the trust in my area, you just can't get the doctors.
Oh no, it's Western Urgent Care. I actually was the founding member, one of the founding members, just John remembers, of Western Urgent Care back in 1995. We set that company up, and it was the best out of our service, as you'll remember, in Limavady in particular. Had a great service from local GPs, and now if you go in to do that work, it's so high risk.
Yes.
And so demanding. If you walk in to one of those out-of-hours shifts, you'll be told there's 100 phone calls behind time. There's a queue of people 35, 40 long, and there's 10 house calls. What would you like to start on, Mr. Robinson? Or sorry, you're Dr. Robertson. This. So where would you like to start? And the young doctors are just going, I'm not doing that.
I'm running.
Exactly. The trust actually suggested to us if we could write, sorry, Chair, through you, write to the local doctors to ask, so would anyone volunteer? Basically, we never got one reply, which was very understandable.
And I just mention that, of course, it's the same doctors often who are working both in hours and out of hours.
Yeah.
And if your workload is unmanageable during the day, you're very glad to be able to get home at night and spend some time with your family. And the potential of that doctor then wanting to work in the evening and overnight is very slim.
I'm not knocking more our own doctors, to be fair about it. They do a tremendous job.
The day job's finishing about 7:30 or 8 now.
Yeah.
Plus you go in at the weekend and catch up. The out-of-hours shift starts at 6. So for me to commit to 6 p.m. out-of-hours shift when I'm not finished until 7:30 or 8, can't be done.
Quite true. 7 days a week.
Well, yeah.
Thanks.
Okay, George. Kieran?
Thanks, Chair. Thank you very much, gentlemen and lady, for your presentation and your briefing. I must say, this is the 2.5 hours I've been sitting in this room, and it's the most depressing 2.5 hours that I've been in this room. And you people were sitting at the back there, and I'm sure you must be disgusted also. So I don't know how long it's going to take us to finish this and complete it, but I want to say to you people that I fully support your campaign to put patients first and back general practice.
Thank you.
100%. I'm sure all the members are the same in this room. I have 2 or 3 questions, but I just want to say, Dr. Black, I mean, I've listened to what you've said. I've heard you on the airwaves on many occasions, and I agree entirely with what you're saying. There's changes in the department. You've criticised the department, and rightly so. There's changes in the department in recent times. Do you think with those changes, I mean, and you said there was 3 reviews, I think it was, and come up with recommendations, and the last review there's 4 recommendations. What do you think your chances are of having those recommendations implemented, given the changes that are in the department now?
The department, the Minister and the Permanent Secretary have a very difficult job. I wouldn't want that job that they have. And the criticism I have for them is not that they don't understand or they don't have the knowledge. They clearly do. I've spoken to both, and I think that they're both well able. And yet, my criticism is that they've chosen not to make general practice a priority. They've chosen other areas. And I think that's where my criticism is, because if this is the foundation of the health service, and the service cannot work without GPs, and we are in the worst crisis in my 25-odd years in general practice. This is much worse than 1990 or 2004. This is back to the worst we've ever seen in general practice. So my criticism, Mr. McCarthy, is that they failed to make it a priority.
Yeah, well, I mean, given what you said, transforming your care, in my opinion, was based solely on the GP, on the at the primary level care, and it's not happening. It's not going to happen. And again, in my opinion, I think transforming care is dead in the water. If we and given what you're saying, you're convincing me more that that's the case, unfortunately, because we supported transforming care as a vision for the future, but it's gone.
What has been a failure with transforming your care is setting the key priorities, setting performance indicators. Nobody could argue with the vision of transforming your care, and we're very supportive of it. I'm sure BMA has been as well. But there has been no outline of how we get to where we want to be, where we're going to be in 2 years, where we're going to be in 4 years, where we're going to be in 6 years. It's been muddling along. You say it's dead in the water. I think it's in neutral.
Well, I mean, that's not very encouraging either, given the aspects of what we thought we were going. 3 questions briefly, and I've got the letter here. The Health Minister announced recently 15 million, and I think Dr. Black spoke about it, investment into GP services. Within this, 300,000 is to recruit and retain GPs. I mean, and your recommendation, you want to see 80 young people, young doctors trained. Is that £300,000 going to do that?
No, they're looking to use the £300,000 for innovative schemes to retain and recruit. So, be it bringing doctors, Dr. O'Kelly described, into under-doctored areas, or to bring doctors back from foreign parts, or to retain older GPs who are about to retire. I mean, it's not. What they're suggesting is not the wrong thing. I think success will be very difficult to achieve, though, given the environment of the workload.
Yeah, right. So it's not going to happen, really.
Well, if you were 59 3/4 and you were about to retire on what is a good pension in the health service, could I persuade you to stay on and do 47 consultations, 172 scripts?
So.
No, I don't think you're going to stay on. I think you're going to go.
But anyway, let's stick to this 15 million. And you did mention 10 million to extend your premises, or if that's what you wanted. But it does say here up to 3.1 million of investment in out-of-hours service, of which you've already said it's up the tubes now too. Where's that 3.1 million? I mean, I'm trying to. Is this 15 million? Is it going to be blown away like other millions, and we're not going to see the benefit of it?
Well, the 15 million is really 5, because the 10 is premises, it's a capital sum.
That's right.
So it's really 5 million. The 3.1 million is a recognition in the department that they know out of hours is in severe bother. Despite the fact that with such a constrained budget, they're taking 3.1 million and giving it to GP out of hours. But to reiterate the point, in 2003, when GPs were running out of hours, we spent 25 million on it. It's 22 this year, plus 3.1 is 25. It should be about 50 million if they had maintained the 6% increase every year that they should have done, but they didn't. And that's why you cannot get doctors to work, because there's 1 doctor on instead of 3. There should be 3 doctors on to run the phone, seeing the patients, and the house calls, and instead 1 goes in and goes, where do I start?
Yeah. And again, on that 15 million, is 1.2 million of investment helping GPs meet demand for blood tests and other diagnostic work. Is that, you welcome that?
Yes, that's enhanced service. It'll obviously mean that we will take on work to earn that money. So what we're hoping to do is bring in phlebotomists to do that. It's again part of TYC. We're actually doing an awful lot of hospital bloods at the minute. My treatment room's bunged. I don't have a capacity to take on more hospital bloods, but it is obviously better for patients if you're going in before your cancer treatment to get your bloods done locally in your GP practice. So if we can get phlebotomists or nurses in to provide that service, that would be a good idea. Right. It's not extra money.
Yeah, I think that the move to recognise that pharmacists could be extremely useful in general practice is to be welcomed as well. And that certainly the college strongly supports pharmacists working closely with GPs in practice, actually embedded into practice, because they can offer an awful lot of support and take an awful lot of workload off us. And we would certainly strongly support any further developments in that regard. And I think BMA would be.
Yeah, there's a good story there, Mr. McCarthy. The Health and Social Care Board is working with us on a pilot to bring forward pharmacists in GP practices. 39 million prescriptions, 2 hours of my working day that I should be seeing patients instead of producing all these scripts. So a pharmacist in a practice could do that work. So the board is going to invest in that this year with a rolling programme increasing up to hopefully a pharmacist in every practice, about 300 pharmacists in total. Still less than the 400 pharmacists and trusts, but I would have to make that point, wouldn't I?
Yeah, for sure. In your paper, you state that the percentage of GPs working part-time is not known. Why is this data not available?
What is full-time? Full-time, some practices tell me it's 9 sessions a week. In face-to-face consultation, some say it's 8, and then the rest of the time is audit, paperwork, education, etc. That's a much higher proportion of face-to-face clinical time than you'll find in any other health environment. So it's really every practice does their own thing, so you'd have to go in and interrogate and check. So I have a part-time partner who seems to work every day of the week now. Why? Because we've strong-armed her into coming into the practice more. So is she part-time or full-time? She works full-time, but she would like to be part-time.
Right, okay. And your paper also states that they are unaware of any visible or positive impact on the £25 million already shifted from hospital services to community primary services in the areas of learning disability. I think somebody mentioned earlier, mental health, resettlements. Can you give us any more details on that issue at all?
My memory of TYC was 86 million going to community, of which 23 million would go to general practice. I don't think I've seen a penny. The investment, just to hone it right down to the investment per patient. In 2009, we spent in Northern Ireland £124 per patient per year. That's what general practice costs. We spent, what, 2,300 or something total in healthcare per patient per year. So 125, 6% of the budget goes in general practice, £124 in 2009. This year it'll be 125. That's a 0.8% increase in 6 years. 6 years. During that time, the total healthcare budget's increased by 35%. So 35% increase in the healthcare budget, and in general practice, the increase is 0.8%. That's a cut of 34% in real terms. That's the sort of thing that we're dealing with.
Right. Finally, Chair, it is a concern that professional bodies are not represented on the Regional Workforce Planning Group. How is the group, your group, engaging with the professional bodies, or that group engaging with the professional bodies?
We had input to the interim report that I alluded to earlier. We had representation on the interim GP workforce group, but not on the overall.
So that must be very disappointing when you...
It isn't. There's a pattern of this. So we are involved in each of the, the individual specialty streams. We're asked to be part of that, but we're not part of the arching group. And it was the same thing in the group that looked at unscheduled care recently. Both Tom and I advocated for positions on the central group there. So I think there's a pattern of the Department of Health operating in this manner.
So in actual fact, they don't appreciate the experience of you people for an input into such a very important aspect of the health service?
Well, I'm not sure why, but clearly I think the professionals have an important role to play, and bring their experience and the patient's experience to that forum.
Right. And finally, is there any way that you can give us any encouragement that there is a light at the end of the tunnel? Because we're all affected. We all have to see the DP at some stage or other. And
the light at the end of the tunnel is GP federations.
Yeah.
In England, we have Simon Stevens, who's a very bright person with a clear idea, and his system, his plan is called the 5-year forward view. So if you want really good reading on healthcare, read the 5-year forward view, NHS England. We actually moved ahead of him. We were anticipated this problem, Mr. McCarthy, and we set up GP federations with 13 out of the 17 already incorporated as not-for-profit community interest corporations, and we will hopefully be able to implement changes, the TYC, the transforming of the system, the shift left into the community through the federations. Mm-hmm. And we've persuaded the board to invest in federations through these pharmacists. And the big advantage, of course, and this is why we set them up as not-for-profit, is when they invest in a GP federation, they're not paying GPs any more money. They seem to have a real problem with that, which is fine. So there's now a forum in the community where they can invest and develop services. And you've seen the strategy document, which we did send you a copy, Mr. McCarthy. You've got it under your pillow, I'm sure. And there's a whole section on that in the federations. It's
So that is
hope for the future.
That is hope for the future.
The federation model has been one that the college has been putting forward from a document in 2007, and we are strongly supportive of it. And it's basically collections of GPs and practices getting together, pulling resources and delivering. I still remain optimistic. I'm one of the 2/3 that won't be retiring in the next 5 years, I assure you. I have confidence that if we are given the tools to do the job, I have confidence in my colleagues in delivering, and I think we can deliver. It's not the total solution, but I think federations offer us a real way forward.
Right. So you're not as despondent as the previous people sitting in those chairs, where they were totally, unless there's millions of pounds coming from heaven, we're going to be stuck in zero land.
They have to fix general practice, and they will. It's inevitable. It's what happened 4 times before in the National Health Service. Which is more important, the National Health Service or general practice? The NHS doesn't exist without general practice.
If you're doing in general practice 90% of contacts as a whole in the NHS, you have to take seriously the problems we have with workforce. Recruitment, retention, returners, all those things are extremely important in order to beef up the clinical workforce. And I think there has been the ostrich, the head in the sand approach, not appreciating that we are going to have a major demand-supply imbalance in workforce. Compounded by the things that we've talked about.
Thank you very much. Can I wish you well? All.
Thank you.
Thank you, Kieran. Pam?
Thank you, Chair, and thank you very much for your time here today. And apologies that I didn't hear all the presentation at the start. I have to say from the outset, I've had the privilege of going out a couple of times to local GP surgery and seeing the work that they do, and I was blown away the first visit, and equally so the second visit, as part from my own experience as an ordinary punter going to my own doctors elsewhere. So I have much respect for the work that you do and much appreciation for what you do, and it's a challenging role for you, and given that we talk day and daily about early diagnosis, so there's much pressure on you as doctors to do the best for us. So I just want to say that from the outset, I really appreciate the work that you do. Dr O'Kelly, the BMA paper states that demands on GPs means that young doctors are choosing not to enter general practice. However, the committee heard that the GP training places are oversubscribed, and that we don't have a problem getting young people to choose general practice. So what I'm asking you is to clarify which is the more accurate scenario.
What we have is that we have an incredibly low number of GPs being trained in Northern Ireland, 65. But there will be no doubt that if we increase to the 111, we will have problems filling all those. And in England, there is about 1 in 8 training places that aren't being filled, and they've had to go to 2, 3, 4 recruitments to try and fill those. So at the minute, it's false in that we are training so few at 65 when we need to be up at 111. Health Education England and the Department of Health in London have stated that we need approximately half of all undergraduates in medicine to be training in general practice. In other words, delivering the doctors that we need for 2020 and 2030. So Queen's has the order of 230, 240 graduates every year. So the maths are obvious there. The reason we get 65 is because the numbers are quite low. One of the other problems then is that we train them, and as I was talking to a young trained GP recently I ran into, and he's working as a sessional doctor in a hospital ward in orthopaedics. Again, for the reasons that it is regular hours, and he couldn't take the stresses and strains of working long hours in general practice. So it doesn't matter. One matter of training them is that when we get them trained, is how do we keep them in general practice? I come back to the working environment.
Can I just mention about that we do need undergraduates to have much more experience in general practice. A lot of undergraduates make up their mind as to whether they want to be GPs even before they qualify. Okay, and if in Northern Ireland we're only spending, and the undergraduate medical student is only spending around 5% of their entire curriculum in general practice, so getting very limited exposure. We are, as John said earlier, we're the third lowest in terms of the amount of time spent in general practice in the whole of the UK. Universities like Keele in England, it's over 30% of the time is spent in general practice. And not surprisingly, a very high percentage of their students all want to become GPs. We are also, as a college, calling for the overhaul of the SUMDE funding so that more time can be spent by our undergraduates out in general practice, getting experience firsthand. Of course, they have to be able to see a workload that is manageable. But we feel very strongly, we're all passionate about general practice. We want young doctors to come into our profession. And so that's something that we would want as well.
That is something that was raised with me locally as well in my visit, so I'm aware of that. The other point I just wanted to make too was I know the part-time working is an issue as well, and we always talk about women and going off to have their babies and all the rest of it, and that's grand, but I noticed from the practice I went to there was actually an awful lot of part-time male doctors as well, and of all ages.
I think yes. I think as a college, we of course are very glad that the gender imbalance that there was in previous decades is now being rectified. We think it makes for a much more balanced GP population if we have 50-50 in terms of the doctors within general practice. We're moving from a very male-dominated profession 2 decades ago to now more than 50% of trainees in general practice are women. In England, I think the figure is around 65% of GP trainees are women. Currently, around 47% of the workforce of GPs are women. And these women are taking, of course, they are taking longer to train, often because they are taking time off to have babies and have maternity leave. They are sometimes having part-time training as well, which is taking longer. But we're not losing those individuals. They are coming into they're getting their full qualification in general practice. The problem is then creating a flexible working life for them. Most female GPs won't want to work full-time for all their working life. They will want some flexibility with that. But increasingly, our male colleagues as well are wanting that flexibility too, because they're finding in general the stress of general practice every day, full-time, is just too much.
A lot of times they're doing almost like a portfolio. Their basic job is within the general practice, which they do part-time, but they're working in other areas. So you may find a GP who has a special interest who's doing ophthalmology or working in the genital urinary clinics, or maybe doing some work for commissioning or for the trust. So you get that. One of my partners who was full-time has gone down to just 2 days a week, but he's working for the Northern Board in dermatology, doing minor surgery. And he made a conscious decision that, to keep himself sane, that he needed to do that. So and I think that is probably a trend that we can't reverse, and that this has to be taken into account. How we work as general practitioners, how we relate to our hospital colleagues, the models will be changing over the next 10 or 15 years, and that's got great challenges for us as general practitioners, but I think we are adaptable and that we can do that and we can still deliver.
The BMA would be equally positive about women in general practice, or sorry, women in medicine, and we think it's very positive. They bring very positive things. Part-time working particularly by female doctors in general practice, it actually does seem to be something that is largely unique to general practice. I mean, participation by women in hospital medicine is much greater, and although I suspect they're probably work a lesser number of hours, the majority of them work full-time, and in fact, one of our members had a grievance case about 4 or 5 years against the Belfast Trust 4 or 5 years ago, and the basis of it was that more women work part-time, and in fact, the converse proved to be the case, that in fact, men among consultants were more likely to work part-time. So it is a characteristic of doctors who choose to enter general practice.
It is very interesting, the whole subject of part-time working, because from my view, I think it's actually a very good thing. I understand it costs a lot of money to, train up doctors, but actually, you're still human, and if you go off to have children, whether you're male or female, there's actually no point in having them. You never see them, and I think there is a balance to be struck. But thank you.
Thank you, Paul. Rosie? Okay, and thanks very much. It's been really interesting listening to what everybody has to say. I was just following on the whole gender discussion. Would you be aware if the department is seriously addressing the issue of workforce composition in terms of gender mix and how that impacts on the workforce?
So we don't think they have been to date, and that's, I think that's one of the reasons why this crisis has developed in general practice. As we were saying, there's much greater participation by women doctors in general practice, but I think that really hasn't been taken into account and has the effects. The evidence we presented, I think there are referred to 33 people coming out of the programme at the end. So I think that's one cohort who've travelled through, and I suspect 65 went in, but 33 come out. And effectively, because those doctors, many female doctors, are choosing to train on a part-time basis, and then ultimately when they go into the workforce, they will more likely work part-time. So, but I think that's been clear, and this trend did not develop overnight. This has been something that's been happening for a decade or more, and I suspect is outlined in the prior reviews that were done, and should have been acted upon.
It has been clear that women are choosing to become GPs for quite some time, and the whole undergraduate, the fact that more women are applying to become doctors, about joining medical courses. So, this is not something that has just happened suddenly. It has been a rolling progress, but there should have been then the foresight to see that this was going to be an issue and that you were going to have more training places in order to just keep the workforce balance, demand supply.
So you don't really, taking all that on board, you don't really then think that they're seriously looking at this as an issue?
They can't be if they are not increasing the numbers of training places.
It also, I think, has had a knock-on effect on NIMTA, where if you don't have the numbers you're expecting coming out, they're still in the system. They have to find practices for them to train in. The expense goes up as well, and NIMTA's GP budget certainly hasn't increased to allow for that. So the blunt answer to you is, I totally agree with you. No, they haven't taken into account.
Okay, that's another depressing aspect then, to add to all the list that we've had today. Would you have any views about how to encourage female doctors to work full-time?
I think, I started off as a full-time GP, I now, like so many, I work more part-time hours, but I have a portfolio career like John, and where we do other things. I'm a Macmillan GP facilitator, involved in education of GPs in terms of cancer and palliative care. So I find that a very useful thing for my own work, but also I enjoy it greatly. So I think it is difficult to encourage people to be full-time GPs for the whole of their careers. Some may wish to just be part-time while their children are small. Some may wish to remain part-time all their working lives. I think it's difficult to be prescriptive about that.
John Humphreys visited his GP, John Humphreys, Radio 4. Sarah Jarvis was his GP, quite famous in our community, you know, as a high-profile GP, and she's leaving general practice because she can't cope with the workload. And he went and spent the day with her, just as you were saying, Ms. Cameron. And she was going home at 4 o'clock, and he says, "What kind of a job is this?" I thought she said, "You worked hard, you're going home at 4 o'clock." She says, "I'm on a half day today. I'm part-time." You get to go at 4 o'clock if you're part-time. Young female doctors tell me that they bring their children in to see them at lunchtime because they haven't seen them for 2 or 3 days. So I know of one that brought her child in to see her on Friday at lunchtime because she hadn't seen the child since Tuesday. I mean, you're going to look at me and go, why would anyone put up with a job like that? And then you have to ask yourself the question, why would the spouse put up with someone working those hours? And that's, you know, it keeps coming back to workload again. Young female doctors work part-time because part-time is like nearly full-time. If you want to make the job more attractive, we have to manage the workload. And the best way to manage the workload is to have more doctors there to do it. It's like a circular argument. It's so obvious, and yet it clearly isn't obvious in certain quarters.
Wonder where.
I just want to echo what everybody is saying about the importance of and the central foundational place of GPs within the whole health system. It's first protocol, and it's you know, part of your, I suppose, your life, you know, your GP. And given all the stresses and you know, the kind of pressures that you've outlined, that, like, it's hard to believe how you know, people function like that. A burning question I have is, how are GPs then meant to find the time to stay ahead of medical advances? Where do you get the time to do that?
That is a good question. We are all appraised on an annual basis, and we have to do audits, and we have to attend educational and show that on a yearly basis. And now, obviously, every 5 years, like all doctors, we have revalidation. But yes, you're doing that in the wee hours. Sometimes we're doing that over, if we can catch a lunchtime, we do lunchtime meetings. Each practice does it slightly differently. We do evening sessions where we work to 6, half 6, and then we'll get a takeaway pizza or Chinese or something, and we'll work through that.
Hardly.
So that's what you do, but you have to stay ahead of it.
Healthy eating.
I know.
No, but it's hardly conducive.
As I say, not as I do.
Effective learning, really. Sure,
Yeah.
isn't it? It's not the best way to be doing it, but okay, I've got a couple of other wee questions here. In terms of secondary care, do you feel that the trusts have made available adequate training or retraining programmes for the medical workforce to meet the shift left PYC requirements?
John?
I think that's a difficult question, and I think part of the problem is it's not really clear yet what that will look like. And so I think the managers are somewhat in the dark about what will be required, but I think this will be a gradual process, and so work in the community, I think, will be done both in general practice but also by secondary care doctors. And so the kind of thing that secondary care doctors are doing, for example, I think home intravenous antibiotics is a good example. So there are a cohort of people who in the past have been in hospital because they have some condition, like a bone infection, which requires they need a very long, prolonged course of antibiotics. And it's now possible to deliver that at home using district nurses service supervised by a consultant infectious disease physician. And so that's the example of the kind of innovative program that fits entirely with TYC. But I think those type of projects need to be developed organically. And it will depend from specialty to specialty. So I'm a consultant in kidney disease, and what we increasingly do is we have a day case unit where we have patients come up and we try to do as much for them as an outpatient, using the facilities in the ward which would have historically been used as inpatient beds. We've converted inpatient beds to day case facilities. But I think it really will depend from specialty to specialty, and that's the kind of organic development coming from the frontline clinical staff that will lead to a shift of care into the community.
Yeah, I mean, I think the communication between general practitioner and our hospital colleagues is so important in that. I chaired the Western Multidisciplinary Respiratory Group for many, many years. And on that, we had our hospital respiratory colleagues, we had physiotherapists, we had the nurses, and we were trying to come up with a strategy of how to improve respiratory care in the West. And we did manage to put in pulmonary rehabilitation. We worked also with the British Lung Foundation, and Chair, you're probably aware of the Old Library Trust and the work they do up there in the gas yard. And we did make progress. Where you have health professionals interacting, sharing ideas, coming up with ideas, it does work. Unfortunately, there was the barriers put in place by, can I put it, the organisation and following the rules of the organisation. And I think if I was asking politicians and yourselves is, yes, we have to show our outcomes, we have to show how we spend the money, but allow us to innovate. You know, don't be afraid of letting us innovate. The college at the minute, our quality committee, our chair is already working in the renal aspect with some renal specialists looking on a care flow for acute kidney injury. So there is work that can be done. We as GPs may see our hospital specialists coming a little bit more into the community. We could think of paediatrics, for instance, dermatology. Why does dermatology need to be a hospital-based specialty? You know, and that's where we can work together.
Okay. Just my last question then. Both of your organisations address the issue of health services reliance on locum doctors. Are there proposals to reduce the need for locum doctors, either coming from the Regional Workforce Planning Group or the trusts?
What's a locum? There are none in the West, there are none in the South. There are a few GP locums in Belfast. The locums have all gone away.
Really?
Canada, New Zealand, Australia. They Snapchat me. Bondi Beach, 5:15, days work done. Cheers me up.
So that, I mean, that's
There are locums
really
for hospitals, I'm sure.
Hospital locum doctors, well,
Yeah, not in general practice
There
anymore.
are. So, I mean, there's always going to be need for some locums because, you know, people fall sick unexpectedly, and there's a shift that has to be filled. And you know, we're seeking to work with the Department of Health to do that on a regional basis. We're having some difficulty with that for junior doctors, but we're seeking to do that to make it cost effective for them. But as you correctly identified, locum payments as well are where there are long-term gaps in often, say, for junior doctors or when a consultant retires, for example, and those posts aren't filled immediately, and so a locum is put in place. And often that's a much more expensive proposition than if there'd been proper succession planning and proper workforce planning to make sure that there were enough people in that specialty.
Thank you.
Thank you, Rosie. And Michael?
Okay, thanks, Chair, and thanks for the presentation. I've been listening here carefully because you heard the previous presentation and the issues there, so we can't bury our heads in the sand about that. That has to be addressed. Yeah. And it's basically the same question I'm asking you, because I'm hearing things about primary care collapse, inadequate workforce retention, retirements, perfect storm, out of hours now broken. So I think it's fair to say we're in an emergency situation here as well.
Yeah.
So it's stabilising the situation. I understand what, you know, as we go forward. How do we stabilise the situation here and now? Because, for example, in terms of workforce, we increased the throughput in the medical school from, I think it was 170 to 250, roughly, in about 2008. That cohort has now started to reach the workplace in the last couple of years. Yet we discover that 50 doctors, young doctors, went off to Australia and Canada last year. So clearly, if we're increasing the workforce throughput and training by 80 or 100, and you're losing half of them to Australia and Canada, that is a situation that the simple maths, as you talk about, is just not sustainable, where that urgently needs to be addressed. You talked about golden handcuffs. What do we mean about that? Retirements, persuading doctors back and so on. There's got to be some sort of emergency plan here. There's got to be some sort of, we're in an emergency situation, we need an emergency response. So what are the steps and what's the budget? Have you guys done that? What is the action? Because budget keeps coming up, pharmacy, a pharmacist in every practice. And that's something, as you know, has been invested, pharmacists in doctors, in hospitals, a key component, a good idea. What are these steps to emerge? Because we can't go on, as you say, Tom, the practice collapses, primary care collapses. This has got to be fixed. There's emergency steps that need to be taken. We've got ourselves in an emergency situation. Emergency steps have to be taken now. And after that, at the same time, working on the medium term.
Chair, Mr. Jamesy brings us to the big picture here and how to solve the big picture. Thank you, Michael. The first short step is the pharmacist in practice, because if the board, bless them, can find the funding to put a pharmacist in every practice, that saves each GP 2 hours and suddenly underpins the workload issue. The 5-year forward view in England is very clear that the shift left needs to take place because hospitals are expensive, hospital doctors are really busy, and we should retain them for the most acutely ill. And the 5-year forward view talks about more than half of all outpatients taking place outside trusts by providers in the community, and those providers will be made up of GPs, hospital specialists, nurse specialists, etc. And that's where the 5-year forward view is moving, and they call it multi-specialty community providers, and we're calling them GP federations here. And yet you and I both know that the really big picture in Northern Ireland is our obsession with buildings and maintaining local buildings. And I know that you are most sensitive to this because you're the people who have to put yourselves forward and ask voters to vote for you. And that's a local thing, and all politics is local. And who's going to close the 10 acute hospitals that we have, and do we need 10 acute hospitals? And if we maintain 10 acute hospitals, and the rotas within 10 acute hospitals that my hospital colleagues have to maintain, we're spreading our resource too thinly across buildings. And we've had Hayes Review. Do you remember that? We've had the Donaldson Review. And in between we had TYC, and they're all very clear that if we take our limited resource and spread it across too many buildings and call each one an acute hospital and then try and establish rotas within them, we won't have enough resource left to do the job right, and that's where we are. So I know Donaldson said he wants an external, it's a great compliment for the politicians in Northern Ireland, he wanted an external international group brought in to say this is what you have to do and sign there and do as you're told. And I appreciate, I've been doing this 20 years, I appreciate how difficult it is. When we went into the Hayes Review with 17 hospitals, we've now 10. What should we have? 5, 6, 3, 4 networks probably, 5 or 6 hospitals. That's the solution, that's the big picture solution. Yeah, I think
That's the big picture. It's the here and now. I'm interested today, tomorrow, this year, next year. if you're hitting a collapse, the time you get a consensus to start dealing with the issues you're talking about, where Hayes talked about the Golden 6+3, it was the Golden 6, then it became the Golden 6+3+, and they're all still sitting there in some shape or form. But it's the here and now. If you're talking about things like primary care collapse, out of hours collapse, this is emergency stuff. So it's this year, next year. The same as the issue we talked about earlier on the weights and all of those patients, thousands and thousands of sitting in pain and distress. They've got to be dealt with. Stabilise the situation now. I think everybody understands what needs to be done. I have to say, as the health minister in those days, there's no way I would have been able to do that next stage. I was able to do the reorganisation and got, as you know, huge abuse all round. The next stage then needs a different type of approach, and certainly ain't me, thank goodness. And I'm not sitting there now, thank goodness. But it's emergency. You need to do something emergency now. If we're training an extra 80 doctors a year, so we're now putting 250 through the medical school, but you're getting such a low number in the GP practice. We're losing so many to the overseas. I mean, that is, yes, you could say that's the environment, but I mean, that is just catastrophic for us.
But I think in terms of workforce, we know what to do. You know, the reviews have told us what's required for general practice, and we just need to implement that, as my colleagues were saying, you know, the increased numbers. There are shortage specialties in secondary care. We need to do, we're beginning workforce reviews for them, but we need to do those rapidly. So that's paediatrics, radiology, emergency medicine, subjects like that. We need to look at the workforce, and that's clearly a substantial issue for general practice. You know, why is the workload so high, and what can we do to reduce it? And we need to look at the working environment and incentives for people to stay. You know, how can we make this attractive? How can we make these jobs attractive?
It's the bit about young doctors going in to train, and on their way through, and then they come out, they don't want to do practice. How do you fix that? That's the wee bit I'm just not catching at the minute. Yes, you say you need more people.
Well, if
but you're getting so few people actually signing on the as I understand it. And yes, there's an argument there, and that's with Queen's about putting more experience for as the students go through, getting them out to GP practices more, and all of that. And that would be an important step, no doubt. But how are you going to get?
The RCGP UK are promoting general practice. They are doing a big campaign, professional marketing campaign to encourage young doctors to become GPs. There's a variety of different moves. I mean, obviously, if you want to increase your workforce, it's going to take some years before you're going to get those extra doctors trained, even if they decided to start increasing the numbers this year, which is really not going to happen.
Well, we did that in 2008, so we increased the numbers, and it hasn't worked out, you're telling me, because 50 went off last year.
Well, 50 left the performers list. I'm not sure if we know the exact statistics in terms of who left for Bondi Beach, or how many, as John says, are actually working in hospitals because they find the working conditions better. But you've got the issue with retention in terms of refresher and induction, getting people who maybe have left general practice for whatever reason, have maybe gone and had a child and then are outside of general practice for more than 2 years. Are you going to them and saying, look, we could refresh and induct you back into general practice? Are you offering retainer schemes to actually keep doctors who maybe only want to work, say, 4 sessions or less per week, back into the system, keeping their professional standards and their education going? So you have those issues that you can do immediately to start and build the workforce. You have got to increase the attractiveness, so possibly bringing in other support workers into general practice. They've talked about, obviously, increasing the numbers of practice nurses. We have the ageing practice nurse workforce as well, possibly skilling up people as advanced nurse practitioners in general practice, pharmacists, John says, and increasing all the support staff, community navigators. We have patients coming to us who don't need medical care. Patients who are coming for everything come to general practice as the first port of call. We need a letter to get a postal vote. We need a letter because we were sick and we couldn't go for an exam. Whatever. Everything comes to general practice. A lot of what we do is not actually in our remit. So a community navigator post of some sort to help that. There's a variety of things that we could be doing. That would
just find your GP federations.
Yes.
How many practices do you see in each federation?
There's 20 practices in each federation looking after a population of about 100,000. There'll be 17 in Northern Ireland. 13 are already incorporated as not-for-profit community interest corporations. The last 4 will be over the next couple of months. So we've managed to do...
Are all your GPs signing up to this order?
Every single one.
Every single one?
Except there's one guy, but I'll talk to him. But pretty much every practice, yes. Every practice has signed up, let's be clear. And what they will hopefully do in the first instance, Michael, is start providing this phlebotomy service so that patients don't have to go to hospitals. The key in terms of workload and what you're describing as the short-term solution to the workload is to get the pharmacists in, because we literally spend about 2 hours a day on acute and repeat prescriptions. And if my 4 doctors had a pharmacist doing that, suddenly we've got 2 hours a day of extra time to see patients and maybe get home and make the job more attractive. And the medical students are staying away from general practice for one very clear reason. They know. They're the most highly informed. They go everywhere, see everything, and they go, I'm not doing that. Why? Because they don't get to go home. So you can see that you got to create a narrative where people go, oh right, so the system has recognised that general practice is in trouble and is starting to apply resource and staff to that. Once you create that narrative, you've solved it. We've done this 3 times before, 66, 90, 2004, and to be frank, I thought 2015 was the year, and I went up to the department and they went, nah, not yet, son. It will be soon.
General practitioners are resourceful. That's the nature of the business. You deal with the unexpected. You have to adapt. And I think, I mentioned in my presentation that morale is at an all-time low. It is. It's rock bottom. But if, as GPs, we can see that, A, people accept that there's a problem, and more than that, that they are starting to do something about it, you know, we will work as hard as we can to make it right. And you may just stop that flow of GPs out of Northern Ireland and out of the profession.
Maybe even get someone to come back. Their experience.
Yeah.
George, did you want?
Just a small
Yeah, go ahead, yeah.
supplementary. You had mentioned about the help that pharmacists could provide.
Yeah.
With the possibility of prescription charges, again, would that deter the pharmacy giving you that type of help?
No, the pharmacists will come in as employees of the Federation working in the practice. So they'll come in and they'll work for the patients, doing acute prescriptions, repeat prescriptions, chronic disease management type things, diabetes, chronic lung disease, looking at yellow and amber drugs and that type of thing. So I don't think the prescription charge will impinge on that. As the BMA, we will naturally respond that we like to see everything free at the point of need, universal and funded by taxation. But you've heard that one before, Anya and Bevan, I think it was. So I don't think that it will affect the help that we're bringing in, is the answer. No.
Thank you.
Paula, did you want to?
Yeah, and it was just to go back on a point that Rosie had made earlier about the medical workforce and the shift left for the requirements of TIC, and both John and John had brought up the words innovation, and I've said it in this committee many times. I've said it in the chamber that, you know, even in my own household we had an innovative consultant in infectious diseases in the Royal who showed great forward thinking and great planning. Not only did she look at the needs of the patient, but also the needs of the service, and also saved the trust many pounds by home treatment. And I know that happens within lots of disciplines within our hospital services, and I know that is the way forward. That's how we're looking. That all fits in with TYC beautifully all I want to ask on that point is, how are those innovative consultants, are they being supported? How are they being supported? By the trusts, by the boards, by the department? Or is that being brushed away? Or, is the support there for that?
Well, the consultants do say to us that often they feel they've got very innovative ideas, and it's difficult to get trusts to take those forward. And I think trust managers often have competing priorities, and that's part of the problem. But definitely, people feel they have innovative ideas and they have difficulty getting those recognised. I think trusts are getting better, but we clearly have some significant way to go.
But we know, and I know from personal experience, you all know of the savings, whether that's bed days, and it's all moving in line with TYC, and also the patient experience and how important that is.
Yeah.
And we can all see it. We can all see that. You can see that. And at the end of the day, if we're all going to be quite clinical about it and look at the savings financially, which we so desperately need in our health service, need to be looking at it a bit more closely. All right, thanks, Chair.
Okay. Okay. Just a final point in relation to workforce planning generally. The original target had suggested a 3% reduction in staff, which, when the department were in front of us a number of weeks ago, they indicated that that was just a working assumption. Do you have views on reduction, increase, what is required in terms of our medical workforce to implement TYC?
The over 85s will increase by 84% in the next decade, versus 65s by 46% in the next decade, rough figures. We're in deep trouble. The last thing we need is fewer healthcare workers. If we're going to look after our old people with complex comorbidities, forget about consumerism and convenience and all that, just our old people with their complex illnesses, we're going to need more healthcare.
So it's certainly not a 3% reduction.
The history is going to give us a real lesson on this in the next 10 years in terms of the ageing population and their needs.
Okay. Okay, well look, can I thank you all? It's been very frank, open, honest and informative for ourselves. I think it is important. Obviously, we're conducting this piece of work because we do feel strongly that TYC is the right vision in terms of the policy direction, but certainly it feels as if the system hasn't responded accordingly in terms of redirecting the focus towards primary community care. And I say that for any amount of sectors. It's a continuous conversation that we have across health, I think, generally. So we'll be looking very closely at the 4 recommendations that you've made there, and certainly we'll be taking them forward in relation to looking for responses from the Minister and the Department. But thank you very much for your time, and please continue to have the communication with us.
Thank you, Chair.
Thank
you very much.
Thank you.
Have a good evening. Get home to the family now.
Okay, members. Moving on to item 8, which is there's a number of statutory rules, so just bear with me here. First one is the recovery of health service charges, 2015, page 53 of your meeting pack. Just again reminding members that the committee considered and approved the SL1 for this rule at our meeting on the 11th of March. There's been no changes to the policy content, and the Examiner of Statutory Rules has not yet reported on this rule, which is subject to negative resolution. Are members content?
Right.
Therefore, the Committee for Health, Social Services and Public Safety has considered the recovery of health service charges, Regulations 2015, and subject to the Examiner of Statutory Rules report has no objection to the rule. Item 9 is an SR, the Health and Social Care Disciplinary Procedures Regulations 2015. It's at page 63 of the meeting pack. Again, we did consider and approve the SL1 for the rule on our meeting on the 18th of March. No changes to policy content since it was submitted, and the Examiner of Statutory Rules has not yet reported. So are members content with the statutory rule? Therefore, the Committee for Health, Social Services and Public Safety has considered the Health and Social Care Disciplinary Procedures Regulations 2015, and subject to the Examiner of Statutory Rules report has no objection to the rule. Item 10 is an SL1, the Animal Feed hygiene sampling, etc., and enforcement regulations, which is at page 72. The proposed rule consolidates 2 provisions into one rule and will make it easier for stakeholders to access relevant information about the legal requirements for animal feed. It's subject to negative resolution. Are members content that the Department makes the statutory rule?
Agreed.
11 is an SL1, the Animal Feed Composition, Marketing and Use Regulations, which is at page 78. The proposed rule again consolidates 2 provisions into one rule and makes it easier for stakeholders to access the relevant information about legal requirements for animal feed, and it's subject to negative resolution. Are members content that the Department makes the statutory rule?
Agreed.
12 is the country of origin of certain meats regulations, 2015. It's at page 84 of your pack, and this proposed rule will transpose the EU regulation which lays down rules regarding the indication of the country of origin or place of provenance for fresh, chilled and frozen meat of swine, sheep, goats and poultry, and it's subject to negative resolution. Are members content that the Department makes the statutory rule?
Agreed.
And another one, we have an SL1, the honey regulations. We're busy today, page 90 of the meeting pack. This proposed rule will meet policy objectives to revoke and replace the honey regulations. It's subject to negative resolution. Are members content to make the statutory rule?
Agreed.
14 is the misuse of drugs, amendment number 2, regulations 2015, page 95 of the meeting pack. The proposed rule will insert certain drugs into Schedule 1 of the 2002 regulations because they have no recognised medicinal or legitimate uses beyond potential research use, which may be enabled under licence, so it's subject to negative resolution. Are members content that the Department makes the statutory rule?
Agreed.
Okay. Well, I think we have to adjourn the meeting because we have no quorum at this point. Okay. Reconvene the meeting. Item 15 is SL1, which is misuse of drugs, amendment number 2, order 2015, page 102 of the meeting pack. And the main purpose of the order is to designate certain drugs as controlled drugs to the 1971 Misuse of Drugs Act because they have no recognised medicinal or legitimate uses beyond potential research, and it's subject to negative resolution. Are members content that the Department makes the statutory rule?
Great.
16 is the Forward Work Programme. Just advising members there will be no meeting on the 6th of May during the week of the election. The 13th of May, the committee will visit the Gum Clinic at the Royal, and on the 20th of May, the committee will host a stakeholder event in the Long Gallery from 2 until 4 p.m. Just asking members to agree then the Forward Work Programme.
Agreed.
Suggesting that the committee office also inquires into the possibility of doing a visit to the radiotherapy unit at Altnagelvin to just view the work that has been progressed there to date. Members agree?
Yep.
Item 17 is matters arising. There's 14 items. Just in the interest of time, I want to draw your attention to a number of them. Page 156 is correspondence from the Minister regarding a draft of the Mental Capacity Bill. Just advise members this is a very lengthy bill and it was sent to members separately earlier this week. To note at this point, page 157 is correspondence from the Board on the pilot for direct access to physiotherapy. Again, welcome. The pilot is now going ahead and will begin in May 2015. Seeking agreement that we would send this on to the Chartered Society of Physiotherapy.
Great.
And are members therefore content to note the remainders of matters
Chair,
arising?
page 140 are the autism therapists. Just to express disappointment that the Minister hasn't seen his way to accept the ABA treatment for some youngsters with autism. I don't know as much else we can do at this stage, but just because I know there are parents that have great faith on the ABA treatment, and they're going to be not facilitated by the the contents of the letter, unfortunately.
Okay, well,
I think there's a letter, isn't there, further on from somebody to do with ABA? That wants
Is there?
to- yeah.
To talk about it.
And we have, which organisation is it that's coming, the
it's
stakeholder event?
All
There's
right.
an individual, I think it's Louise O'Neill,
I've met with her a few
who's going,
times. Yeah.
subject to committee agreement, be invited to the stakeholder
Yeah, she's,
event.
well, hopefully when we go through this, we will be inviting her along to deal with some of that issue.
Right, okay, that's grand, fine.
He's
Thank
okay.
you.
Okay, then, where, physiotherapy, okay, and members are content to note the remainder of matters arising. Under correspondence then, there's 25 items of correspondence, again, just a number of them. Page 182 is correspondence from the Committee for Education, requesting the committee's view on the Special Education Needs and Disability SEND Bill. Just to advise members that myself and other committee members attended the stakeholder event organised jointly with the Education Committee on the 18th of March. Very good event. The event focused on access to the school curriculum for children with special educational needs. But one of the issues many of the stakeholders raised was the lack of formal cooperation between health and education services as an issue of concern. I would suggest that the committee writes to the Education Committee and indeed to, I think, to the Health Minister to ask if there's consideration as to a formal duty of cooperation between the two departments and whether the SEND Bill could be used, could be strengthened by looking at that cooperation between the two departments.
Agreed.
The SEND Bill also includes provisions relating to the rights of children in respect of access to SEND provision, specifically clauses 9, 10 and 11, and the schedule transfers rights from parents to their children. Again, members, I'm asking that we would write to the department to ask whether they have any comments or concerns in relation to these provisions in terms of particularly how it would link with the forthcoming mental capacity bill.
Agreed.
Page 208 is correspondence from Voice of Young People in Care, asking that the committee declare the 19th of February 2016 as an NI Care Day, asking members if they're content to forward this to the Minister and ask for his support, and write to VOIPEC to advise that the committee has done so.
Great.
Again, asking members are they content to invite VOIPEC to the committee stakeholder event on the 20th of May. Right. Thank you. And page 218 is correspondence it was previously raised from Louise O'Neill, requesting a meeting with the Chair and Deputy Chair of the committee to discuss autism spectrum disorder.
Right.
I'm asking members to agree to invite Ms O'Neill to the committee's next stakeholder event.
Great.
And page 219 is correspondence from Amnesty International, requesting a meeting with the committee to discuss its report on barriers to access and abortion services. Again, I'm asking members if they're content to invite Amnesty International to the committee's next stakeholder event on the 20th of May.
I was going to suggest, Chair, that we actually get the presentation because there's a lot of detail in it and there's very important findings, and I think a presentation to the committee.
Can we access the presentation in advance of the 20th of May? Yep. Can we access it? Can we get that copy of the presentation to members?
Just to clarify, do you mean, is there a written presentation that the organisation have
Yes,
prepared?
there's a report.
Right, yes. Get the
Can we
copy
do
of the
that in
report.
advance of the 20th of May, and then if we need to follow up on it? Would that
Okay.
be?
I was wondering if she could come to present to the committee rather than part of the stakeholder event.
Just what other members feel about it. It's just in terms of timescale at this point, actually fitting it in before the stakeholders. I would suggest at this point that we would do the stakeholders event with her and then look at follow-up.
I would agree.
There's
We
so
okay?
many that we get through that we would all want to see in front of committee, and I think
I'd just be mindful of that.
mindful of that.
Yeah. Although it's
And
Okay.
I would say at some stage it will be coming. We'll have lots of committee once with the Justice Ministers. Once that bill starts to travel as well, we will have different.
well, if we can get access to the report circulated to members, invite Amnesty along to the event on the 20th, and then look at follow-up. What sort of form of follow-up needs to be taken then? Okay, page 220 is correspondence from Parent NI regarding hosting a meeting of the committee. Again, I'm asking members if they're content to invite the group to the next committee stakeholder event on the 20th of May.
Right.
We're going to be busy that day. And correspondence then on page 221 from Strangford Bay Lodge regarding its facilities for those affected by disability. Again, asking for members' agreement to invite them along on the 20th of May.
Yeah, I mean, is there not an invitation out for you to go to visit Strangford Bay? I think there is. I would suggest that if you had the time, you should, but it's a fantastic facility.
Well, again, I think what we can do is invite them to the stakeholders event and look at actions coming from that. Okay, page 222 is correspondence from the Head of Psychological Services at the Belfast Trust to the Department regarding cuts to the clinical psychology training budget, asking members if you're content to write to the Regional Workforce Planning Group to inquire about how this has been incorporated into the workforce planning for T-Waste.
Great.
Item 19 is any other business.
Yeah, Chair, just very briefly, members will know that we lost a young man from Newtownards as a result. We understand legal aid. I wonder, would there be any merit in the committee writing to the Minister to suggest, I mean, there's a campaign building up again to make the availability of legal highs illegal, to prevent further deaths, unfortunately.
I mean, some of these issues were being taken forward by Justice in relation to the powers that were required, but we could certainly write to the Health Minister and ask him for progress on that.
I think that would be a good idea. Thanks very much.
And I think that's a good idea, because we did have in our last stakeholders event, we had a group of parents, mothers,
that's
that were
right.
in,
That's right.
and pointing out the difficulties that
17-year-olds.
they were facing. So maybe worth keeping on with that one.
Okay, and item 20 is date, time and place of next meeting, which is on Wednesday the 22nd of April, starting at 2 o'clock in the Senate chamber. Thank you.
Thank you, Chair.